make sure that you're using your words to describe these physics principles and these artifacts rather than just sort of thinking through how they're happening. So we'll start out just by talking about how this image is created. And, you look at them at a daily basis, but if you think about this, what we have are reflections that have come back from the anatomy. And those reflections are placed in a specific location horizontally and vertically, and then they are of a particular strength or amplitude. And the instrument uses those three pieces of information to create this image. So let's talk about depth on the vertical axis. We use a pulsed echo technique, which means a pulse of ultrasound is sent into the body. It reflects off of structures and returns to the transducer. That reflection return time is what determines depth. This is the equation that is used by the instrument to do that. Depth is equal to the propagation speed of the sound in soft tissue times this reflection return time, of course, divided by 2. So the potential errors in this have to do with if the propagation speed is not the assumed 1540 meters per second of soft tissue, or if the return time is off because of multipath or reverberation situations. And we'll look at artifacts from all of these areas. Next, we'll talk about the positioning of the echoes on the horizontal axis. So the beam is moved through the patient in this sweeping action in order to create the real-time image. So the instrument knows the direction that the beam was sent out, and any reflections coming back from that beam are placed along that line. So some potential pitfalls and artifacts here are if we have ultrasound energy that is outside of the primary beam, which are called grating lobes and side lobes, or if we have refraction, which is the change in direction of the sound beam as it moves through the tissue. And then lastly, we have the amplitude or brightness. So the brightness of the echoes on the screen is determined by the amplitude of the returning reflection. Higher amplitude is a higher or brighter reflection. So some pitfalls here have to do with the type of reflector that we're talking about. And this is, again, where you're going to want to make sure you're using your words. We'll talk about specular reflectors versus diffuse reflectors. We'll talk about the angle of inclination and attenuation properties. So now we know what the instrument knows. It really knows three pieces of information about each reflection. It knows the strength, it knows the direction that the beam was sent out, and it knows the arrival time that that reflection came back. From those three pieces of information, there are many assumptions that are made, and it's unfortunately these assumptions that result in the artifacts that we may see. First, we'll talk about strength. So the assumption is that the strength of the returning echo is related to the anatomy or the interfaces that it hit. But the pitfalls in that regard are that the instrument assumes a standard attenuation in soft tissue, which is 0.5 decibels per centimeter per megahertz of frequency. Unfortunately, not everything that we're imaging through is soft tissue. So that attenuation is not a constant. And when the attenuation is different than what is assumed, we get artifacts, specifically shadows and enhancement. Typically with echo imaging, you tend to see less areas of enhancement, but we see lots of shadows that we'll look at. The other pitfall is there's an assumption that the beam is the same strength within the beam itself. And we have an area where the focal zone is. And so there can be what's called focal banding artifacts where the focus is. Now, sometimes I might be talking about something that you think to yourself, I've never seen this. Well, part of the reason that you've never seen, I hope, focal banding is because the sonographers that you work with specifically turn down the TGC where the focus is, so you don't get that banding effect. So sometimes I'll talk about artifacts that could be there, but hopefully you've never seen, and that's because you're working with sonographers that don't show you those things. So here's a classic example where we have some shadowing from MAC on this long axis. The other assumption that the machine makes is, we talked about the direction. So it knows the direction that the beam was sent out, and it assumes all reflections come back from that beam. The pitfalls are that it may not go straight, so it may refract, or it may have side lobes or grating lobes, and those are ultrasound energy that is outside of the primary beam and not in the same location. So any reflection that's created by the side lobes and grating lobes will be put in the wrong place. And typically that's going to be horizontally this way, which is why you see what looks like a pacer wire going through the RV free wall. And then lastly is arrival time. So the instrument assumes that the sound went straight down and straight back, and it made that path once, and that it's traveling 1540 meters per second. So again, excuse me, if it makes the path more than once or doesn't go straight, that takes more time. And so you end up with artifacts that are improperly positioned vertically on the screen, or the sound may not be going 1540. And there's one specific situation, I have an artifact to show you of that. Okay, before I go any further, both of these are really good articles that I would highly recommend that you review. And this avoiding misdiagnosis and misdiagnosis, I'm actually using video clips from that article in this lecture to show you how some of these artifacts occur. All right, so here's the first case we're going to look at. There's a lot of artifacts going on here, which is typical, but we're going to focus on what is this in the RV. So you can use your words and say there's a hyperechoic structure in the RV and it is producing this shadow artifact. You can see the shadowing through the septum. And this, of course, is a shadow. And a shadow is described as echoes having the wrong strength, in this case, no strength because they're missing. And that's because of a highly attenuating structure, in this case, this pacemaker wire. So shadow artifacts can be from various things. We can have them occurring from calcium, this calcified mitral valve, which we saw before, and catheters or other wires that we just looked at here. And another common time is prosthetic valves, of course. So this aortic valve with the shadowing. What's important for you to remember as well is that the shadows shadow the 2D image, and they also shadow the color. So common questions I would think that would be asked of you are, if you have a prosthetic mitral valve, for example, you cannot evaluate for MR in the apical window because it's going to shadow the color as well as your spectral Doppler. It has to be evaluated from the parasternal long axis, for example. This is an example of, I'll show you this case a little bit later. This is massively dilated right atrium and right ventricle. But my point is this patient has a prosthetic mitral valve, and it's difficult to get pulsed wave of the pulmonary veins, again, because you can't get past the valve. So remembering that shadows are not just 2D, but they're color and they're spectral and continuous wave Doppler as well. Here's another case. Is this pacer wire going through the RV free wall? So I showed you this before. Clearly the answer is no. And this is from a grating lobe, which you'll hear people use the term grating lobe and side lobe a little bit interchangeably. And because of that, you'll even hear people just say lobe artifacts, which I think is a little bit too abbreviated. Specifically, a side lobe is ultrasound energy outside of the primary beam that can happen with a single element transducer, which we do not use for duplex. That would be like a handheld, continuous wave pencil probe kind of thing. Grading lobes are, again, ultrasound energy outside of the primary beam, but they specifically occur in array transducers because of the multiple crystals that are lined up together to make an array. So in our 2D imaging, where we're always using an array, this case we're using a matrix 5.1 megahertz, those are probably grading lobes. Which actually makes me think of one thing I want to talk about here real quick. So as equipment has gotten better, you see less of some of these artifacts that I'm showing you. And the reason for that is because the engineers have been able to do things with the equipment to either reduce the reason that the artifacts happen or to filter them out so they're not displayed. So harmonics, when we're in a harmonic imaging mode, which is almost all the time, those inherently are going to have less of these artifactual echoes because they can filter out the noise better. You'll see occasionally that we go out of harmonics, maybe on a subcostal view, because harmonics tends to not penetrate as well. So if we really can't get through the subcostal, we might go out of harmonics, and then the image doesn't look very good, but at least you can see something. In addition to that, we are almost always using a matrix transducer, which is where it's going to say usually X something. This happens to be Philips. On other equipment, it might be labeled differently, but it's a matrix transducer, and those are the 3D transducers, and they allow the beam width to be considerably more narrow than this in the slice thickness plane or elevation plane than a standard transducer. Occasionally, you will see the sonographer change to like an S51 or a standard phased array. The reason they do that is on some, the X51 is slightly larger, just a little bit bigger than the phased array. And on some patients, their rib spaces are so small, you really have a hard time getting in between them with the matrix. So they'll switch to the phased array. When that happens, you might see some more of these artifacts showing up. So just a little explanation. Now, back to what I was saying. So this artifact of seeing this pacer wire is because of a grading lobe. And here is showing you how these grading lobes happen. I'm going to stop it right here. So here's the primary beam, and these are the grading lobes or side lobes. Okay, this particular article, they called them side lobes. You can't tell the difference. Okay, so the instrument is going to assume any echo that comes back is coming from where the primary beam is, because it doesn't know that these grading lobes exist. So you can see in this frame, the beam is over here, but the grading lobe is this way. So when the grading lobe hits this reflector and it goes back, it is displayed as if it is where the primary beam is. So you have artifacts displayed incorrectly in the horizontal plane. Now, what you have to remember is that this beam is a three-dimensional beam, which means you also have grading lobes that are coming out in the elevation plane as well. But on this example, here's where the primary beam came out. The side lobe, the primary beam came out this way, and this is the side lobe. So the side lobe hit the pacemaker wire, but it displayed it as if it was over here. So that's how a grading lobe might cause that artifact. And here is similar artifact, but it's evaluating or being able to see this happening in the, in the elevation plane. So in this subcostal view, this pacemaker wire is being hit by a grading lobe, but the grading lobe is coming out in the elevation plane, hitting the RV a little bit more anterior, and displaying it as if it's going through the septum. And here's a grading lobe that you might see a lot. Sometimes people call these a rib artifact. All that's saying is there's a grading lobe coming out and it's hitting a rib or something else and displaying this band of echoes coming across. And we can try to get rid of that by turning the TGC down there. Sometimes that helps. The other thing that can help get rid of grading lobes is if you change the position of the focal zone. Sometimes that will get rid of them. And the reason for that is the grading lobes are caused by the firing sequence of the transducer and making those crystals interact together. And so if you change the focus, it changes the firing sequence and it might make that grading lobe go away. This is a very common type of artifact. Okay, here's another case. And in this case, the question is, how many hearts does this patient have? So this parasternal long axis, and what is going on here? Well, what we have is a mirror image artifact, and we have the left ventricle being mirrored down here. And we'll kind of show why that happens. Oh, shoot, sorry. Okay, so if you look at this diagram, the primary beam came out, hit the structure, went back. Then this beam came out, hit a strong reflector at an angle, and it went off this direction, hitting this structure again, angled back here and went back. So this is a longer return time. So this real structure is mirrored too deep. And that's what you have happening over here. So the beam came down and hit the pericardium, which is at an angle. So then the beam went this way, and then it came back, and then it came back. So all of this gets mirrored down here. You may or may not have seen this. If we're imaging quite deep, you can see it. And voila, if we decrease the depth, that artifact's still there, but you can't see it. Okay. Other than that, there's no real way to get rid of that artifact. It's going to just be there. This is an example of it that I created. This happened to be doing an abdomen exam. So I just reversed it so it looked the right orientation for you. So here's the RA and the IVC. And this is a mirror image of the IVC down below. So again, the beam is coming this way, and then it bounces here, and it bounces back, and it goes back. So this gets mirrored here. I could get rid of it a little bit by turning the gain down a little bit. I didn't change the scale, but the other thing is if you heel toe your transducer and change the way the angle that the sound is hitting the vessel wall, sometimes it'll make that mirror go away a little bit. All right, there is so much going on in this case in terms of artifacts, but the one we're going to focus on, this is a patient, this is an apical 4-chamber, and this patient has a Star Edward mitral valve that was placed in 1986. Now we're getting to the point that you probably are not going to see these valves anymore. This patient unfortunately is deceased, but I think that it still becomes important for you to know some of the pitfalls and complications with these valves for a few more years. So this patient has their valve in their mitral position, has a massively dilated RA and RV over here. But what we want to talk about is what this arrow is pointing to. So this is a reverberation artifact. This is a ball and cage valve. So the cage is going here and the poppet is going back and forth. And you can see that there's a reverberation artifact of this displayed here. So reverberation looks like this. When reverberation happens, the sound beam is bouncing between two highly reflective structures. Now, those two highly reflective structures might be something like this, which is the case here. It's bouncing, in the valve. It can also be that one of the highly reflective structures is a transducer. So the sound can actually reflect from a structure back to the transducer and then make the path again. So when the sound is bouncing, that's of course taking up more time. So what you have are equally spaced reflections of decreasing amplitude, and they are deep to the second strong reflector. So on this valve, this is your reverberation artifact here, deep to the second strong reflector, and you can see they're equally spaced. Here's another reverberation artifact from the same patient, pacemaker wire, and you can see it down here. So what's happening is the sound is making the path again and hitting the transducer and then going all the way down here. So they're equal spaces here to here. And then this is common reverberation artifact where we're hitting the surface. Usually the pericardium is doing this and going back to the transducer. A type of reverberation is called comet tail. Some people will also call this ring down. I don't get real worked up about interchanging those two terms. Some people do. They are actually two different things, but for our purposes today, we'll just pretty much stick with comet tail. So comet tail is like short range reverberation. It's this that you're seeing right here. The sound is bouncing between two highly reflective structures that are really close together and giving this comet tail type of image. This is very common near the lung interface, and the sound is bouncing in the space, and the lung is highly reflective, so it causes this comet tail. As you can see them right here, and on this transthoracic right here. And if any of you have done lung ultrasound, a normal lung ultrasound shows these comet tail artifacts, and that's because the lung is, has air in it. Here is a mitra clip, and you can see the comet tail coming off the mitra clip. Now here's an example of consolidated lung, which I just thought I'd put this in to show when the artifact is not there. So this is abnormal. You would expect to see the comet tail artifacts that I just showed you when you have normal lung, and this consolidated lung doesn't create those comet tail artifacts because there's no air here for that sound to be reflecting through. So this is the consolidated lung in this pleural effusion. So that one other thing I wanted to talk about relative to this Starr-Edwards ball and cage valve is the phenomenon of propagation speed. And the poppet in these valves is silicone, and it has a propagation speed that is not 1540. It's slower than that. So it's kind of hard to tell on the transthoracic, but when you look on the transesophageal, the poppet doesn't really look round. It looks kind of oval shaped and long. And that's because of this propagation speed error. And even though this isn't something that's maybe super important on a clinical aspect, people really like to ask boards questions about this because it's a cool physics thing, I guess. So when the propagation speed is slower, as it is in this valve, then that means that the echoes are going to be displayed too deep. And so it's going to make this poppet look longer in it's sort of oval shaped, and it's also going to make the left atrium, if you can get around the valve and see the wall, it would make the wall display too deep. Okay, so that's just something to remember. And near as I can tell in cardiac imaging, that's about the only time that you have a propagation speed error. In other kinds of imaging like liver lipomas, we'll see that propagation speed problem as well. All right, so in this 4-chamber, we can ask the question, what is missing? And you may or may not even notice it's missing because you get so used to seeing it missing, right? So the intraatrial septum is missing right here. So the reason that's not seen is because we're parallel to that specular reflector instead of being perpendicular to it. So we'll be able to see that better in a subcostal. So here's our subcostal, and you can see the very thin area of the fossa ovalis nicely. So this gets us into the discussion of specular reflectors versus diffuse reflectors and how you need to image them. So in this example, we really need to image the septum at 90 degrees or close to 90 in order to be able to see it. So specular reflectors are large, flat interfaces and boundaries. So things like the valves, the vessel walls, endocardium, pericardium, etc., like this example. And we need to hit them at 90 degrees so the sound reflects straight back up and we can see it. Scatter or diffuse reflectors are small interfaces that cause the sound to just scatter in all directions, some of that getting back to the transducer, which is called backscatter. And that's what creates the image. The diffuse reflections also happen at rough boundaries as well. So the image that is created that comes from, say, the myocardium, the liver, those are all diffuse reflectors, which is why you can image them from any different angle and they look relatively the same. So again, in this long axis, the pericardium is a specular reflector and this myocardium is a diffuse reflector. And if you notice, well, just up here, so the myocardium here, diffuse reflector. Now the endocardium on either side is more specular. So if we hit a specular reflector at an angle that is not 90 degrees, we have the chance of not seeing it, right? Because the reflection goes off in a different direction and it never gets back to the transducer. So specular reflectors are notoriously the ones that cause most of our artifacts. So basically everything that I've talked about up until here. So we have reflectors that are missing, we have reflections that are in the wrong location or the wrong amplitude. As opposed to diffuse reflectors, because of how the reflection is created, you can angle from different ways and it still looks relatively the same. So here's an example of that. If you look at the septum in this region where the arrow's pointing, it looks like the septum is more hyperechoic than it is in any other place in the septum. Well, the reason for that is because our beam is exactly perpendicular to those specular reflections, the endocardium on either side at that location. And other locations, it's not as perpendicular. So it's off by just a little bit. So that's completely normal. Again, you've probably gotten so used to seeing some of these artifacts that you just ignore them. But we should probably be able to explain them. So this explains why we do our linear measurements from the parasternal long axis window, because we're perpendicular to the wall interfaces and can get better measurements from them, right? We don't do our linear measurements, say in the 4-chamber, for example. We do them in the long axis. And again, LVOT and annulus and aortic root measurements will be in this long axis view. So since we're talking about angles, I thought this might be a good time to highlight that we just said when we're doing 2D imaging of specular reflectors, we want to be 90 degrees to the echo. That's exactly opposite when we do Doppler, right? So with Doppler technique, we're going to get maximum Doppler shift if we're at 0 degrees. And we get basically no Doppler shift when we're at 90 degrees. So we're going to talk about that physics phenomenon here a little bit. What I want you to remember is that we always are displaying a calculated velocity. We are not measuring the actual velocity of flow. What we're measuring is a Doppler shift. And from that Doppler shift, we calculate a velocity. We have to have an angle that's less than 20 degrees in order to get a relatively accurate calculated velocity. That's why we do most of our Doppler from the apical window. So these are like 3 equations to look at. So what the instrument knows when it comes to Doppler is the Doppler shift frequency, okay? What it knows is the frequency that it sent out and the frequency that comes back, and the difference between those is the Doppler shift frequency. Then the instrument puts that Doppler shift frequency into this equation to calculate the velocity. So if we manipulate this equation to here, we go, okay, here's the Doppler shift that the instrument detected. It knows propagation speed. It knows the frequency that was transmitted. And the instrument assumes that we're at 0 degrees. And the cosine of 0 degrees is 1, so it has no effect on this. So the calculated velocity comes from the Doppler shift and an assumed 0 degree angle. So right here, the cosine of 0 degrees, 1. The cosine of 90 degrees, 0, which is why we don't get any Doppler shift at 90 degrees. Okay. So the things that affect the amount of Doppler shift, the change in Doppler shift, are the following. One, of course, is the velocity of the reflector. So if we're looking at blood, of course, the faster it's going, the more Doppler shift there will be. The other thing that affects the amount of Doppler shift is the frequency of the transducer that we're using. And echo transducers are designed to have a lower frequency for their spectral Doppler in order to reduce the amount of Doppler shift that happens. This is to minimize aliasing. We'll talk about it in a minute. And then, as I said, the angle. So those 3 things affect the amount of Doppler shift. We're just going to talk about this a little bit more because I think it's a super important concept. So this is what the instrument assumes happens all the time. You have a Doppler shift frequency that has occurred. You're at 0 degrees, and it calculates this velocity. So you're getting the accurate and maximum velocity. If you are not at 0 degrees, say you're at 30 degrees, this is the scenario that happens, okay? You get less Doppler shift because you're at 30 degrees. You don't tell the instrument that you're at 30 degrees because we don't angle correct in cardiac imaging. So this reduced Doppler shift is going to result in a velocity that is slightly less than what it should be. So any angle that you have that is more than 0 is going to result in a slight decrease in your velocity, calculated velocity that you're measuring. I put this slide in here just because I think it's somewhat helpful if you know a little bit about what other areas of ultrasound imaging do. And this is what happens in peripheral vascular. So in peripheral vascular imaging, we can't get 0 degrees. It's impossible. So what we do in that scenario is an angle correction. And when we put an angle correction on the Doppler beam, we're telling the instrument we're at roughly 60 degrees, okay? And so the instrument puts the cosine of 60 degrees into this equation to correct for this reduced Doppler shift so that we get a more accurate velocity, okay? We never do this in cardiac imaging because there is some degree of error in this calculation, and we don't want to put another layer of potential error into our pressure gradient calculations. So in cardiac imaging, we never do this. Instead, we always try to get an angle that is less than 20. Oh, and I should go back. Of note, 60-degree angle reduces a Doppler shift by 50%. So without that angle correction, you're going to have a velocity that is half of what it should have been. So we can see this whole scenario playing out in different ways. Here's a parasternal long axis of the LVOT. And when you look at this, you'll notice, number one, you don't see flow filling the LVOT. Part of that's because we're at 90 degrees. The other thing is you don't see aliasing happening here because you don't get as much Doppler shift when you're at 90 degrees, right? When we look at the same patient and we look at the LVOT from the apical 5 chamber, now you see the flow filling it. You can see that there's some aliasing as it going through, not because there's a stenosis, but because we have more Doppler shift because we're at close to 0 degrees. All right, so this explains why we do TR the way we do TR, right? So we always evaluate for TR from at least 3 windows, the inflow, short axis, and apical 4 chamber. And what we're doing is we're hoping that between those 3 windows, we are getting an angle that is close to 0. So therefore we use whichever velocity is highest from these 3 windows. That's the one that we use to calculate the pressure gradient, because we know that velocity is the most accurate because we were closest to 0 degrees. Of note, even if you're at 45 degrees, you have a 30% reduction in velocity calculation. So it's something to really remember. Here's an example of that. Here's a TR jet from the inflow, and it's a good angle, so we can tell that's going to be the best one. Here's our inflow and the velocities calculated at roughly 3 meters per second. In the short axis, we get 2.7, and in the 4, we get almost 3, 2.9. Okay. So what other scenario do we assess the velocity from multiple windows? The answer to that is aortic stenosis. So anytime there's AS, we must use the Pedoff transducer, and we must measure the velocity from the apical window, from the right parasternal window, and from the suprasternal notch. And whichever of those 3 gives us the highest calculated velocity, that means that's the window where we were the closest to 0, and that's the one we want to use. So again, my goal here is that you already know that that's what we're supposed to do. My goal is that you understand why we do it. And the Pedoff transducer gives us some higher velocities because it has such a smaller footprint, so we can get a better angle between those ribs than with the duplex. And when we should do this is anytime there's AS, and you should also use the Pedoff anytime there's a prosthetic or repaired valve, whether that's in aortic position or mitral position. Excellent. So just to forewarn, I may not get through this whole talk, but I'll share the slides and you guys can look at the last ones on your own, but I'll try to get through it. Here's another case, and this is suprasternal notch of the arch, and there's 2 artifacts with the color here, and you know what they are. There's going to be aliasing and there's going to be a mirror image. So the aliasing, this gives me a chance to talk to you about aliasing right here. Notice the color wraps from blue to yellow with no black in between. That's how you know this is aliasing, as opposed to here where it's red and black and then blue. That's 2 different Doppler shifts happening from 2 different directions. And of course, the black is where we're at 90 degrees and you're not detecting any Doppler shift. So aliasing occurs when we're using pulse wave Doppler. Color is always pulse wave Doppler. And this is when the Doppler shift frequency exceeds what is known as the Nyquist limit. And the Nyquist limit is 1/2 the pulse repetition frequency. So the pulse repetition frequency is how fast we are pulsing that sound. It's like a sample rate. And if the Doppler shift exceeds 1/2 of that, then we're going to have aliasing occur. The PRF is changed by changing the scale right here. So the higher your scale, the higher your PRF is, and therefore this aliasing would start to disappear. In addition to that, though, you would see less flow, all right, because you'd be focused more on the higher velocity flow. So we tend to leave this scale so there's maybe just a little bit of aliasing like this so that we get the whole vessel filled in with color. Now, the pulse repetition frequency is limited by your depth. You can only increase it to a certain point based on depth. And the deeper your imaging, the slower your PRF has to be. Otherwise, you don't know depth information. So in cardiac imaging, we can measure up to roughly 2 meters per second without aliasing, with using pulsed wave. And then if the flow gets over 2, usually we're into the aliasing range and have to go to continuous wave. So here's an example where we have reduced the aliasing in this one, but you can still see that there's a little bit of a mirror image. This mirror image happens from what we've already discussed. The sound is bouncing within that aorta and going back. So we have a mirror here. Here's aliasing with the pulse wave Doppler, which you've seen many times. So this flow is coming up and then wrapping around to here. So once again, just to review, in this example, our pulse repetition frequency is too slow to see this AI that's aliasing. How can you get rid of it? Of course, we can move the baseline down, which is basically a cut and paste. Once we hit a certain point, that won't suffice, and we can increase the scale, which is increasing the PRF, as we just talked about. Again, we can increase that to a certain point, and if it's still aliasing, then we have continuous wave Doppler or high PRF that we can go into, which we're going to talk about. So here's continuous wave Doppler. So we're able to sample that velocity that is just over 2 meters per second without aliasing. Before I start talking about continuous wave, I want to mention the operating frequency. So one way to decrease the amount of Doppler shift and therefore decrease the aliasing potential is to use a lower operating frequency, and your transducers are designed that way. So even though this is a 5 to 1 megahertz 2D imaging, the pulsed wave Doppler is 1.6 megahertz. So it has a little bit lower frequency for that. The color Doppler frequency is 2.5, so it's a little bit higher. The reason for that is if we have aliasing occurring with a color Doppler, it's not ideal, but it's not terrible. If we have aliasing occurring with our pulse wave Doppler, that limits our ability to measure the actual velocity, right? So they drop the operating frequency a little bit lower so that our aliasing potential is reduced a little bit. So here's an example that you've all seen. If we want to know depth information, we have to use pulse wave Doppler. Oh, sorry, there's a typo right there. We have to use pulse wave Doppler. So if we're going to sample the LVOT, we use pulse wave Doppler. There we are, perfect. And that samples roughly 0.5 centimeter proximal to the valve. Then if we're going to get a high velocity information going through the valve or the LVOT, depending on the situation, we go into continuous wave. when we have situations where we have an obstructive process and we want to measure the velocity and we need to know the location, we have to use a combination of pulse wave and continuous wave. So in this example, we have mid-cavity obstruction, and the continuous wave, all right, is showing us that high velocity. But in order to know where, we're going to need to walk the pulse wave down through it to find the level of the obstruction. So I know all of you are very familiar with that. It's such an important concept. I wanted to make sure to cover it. You will not see high PRF used very much, if at all, but I do think it's important for you to know what it's about. Typically on the equipment, we have it disabled so that we only turn it on when we need to, so we don't go into high PRF by accident. This is when you're in pulse wave Doppler and you increase the PRF to a point that you have range ambiguity. Range ambiguity means you don't know the depth information. So if you notice when we go into high PRF on this example, I don't know, this one is hard to see. Yeah. It didn't display quite like I'd like, but there's actually 2 sample gates, okay? So when you go into high PRF mode, you get 2 gates displayed. That's the instrument telling you, you have asked me to pulse so fast that I don't know if the Doppler information is coming from this location or this location, okay? So why would we do this? The advantage is that it allows us to measure a velocity without aliasing in a specific location, although there is potential for contamination because you have 2 gates. And that's the disadvantage. You have some potential for contamination. Basically, the only time that we do this is if there is, say, a mid-cavity or LVOT obstruction and AS happening at the same time. Then you can try to get a flow velocity at specific locations without contaminating with continuous wave. The other time, as in this example, is sometimes if you're trying to Doppler the aorta, if the patient has a large BMI, this depth may be so much that you have to get into high PRF mode simply because the aorta is so deep. And this was just an example trying to show that this patient has some AS and LVOT obstruction. So when you go through with continuous wave, it's hard to separate out where the LVOT obstruction is and where the AS is. Which then brings us to contamination, and I'll probably get through this one and then I'll have to stop and you can look at the rest of them when I send the slides. So anytime that you see a patient that has an MR jet that is coming towards the septum or coming anterior on this 3-chamber, you have to be very concerned about not contaminating the MR flow and calling it aortic flow, because then you'll overcall aortic stenosis, obviously. So that's what can happen with continuous wave Doppler, is this contamination problem. So this patient actually had TR, which was by the septum, and then they had some AS, and they had MR. And so separating all that out, there's a number of ways, which I know you've discussed in terms of wide jets versus narrow jets and so forth. The most important thing, at least for me in this talk, is for you to recognize when that potential problem is going to happen. And then this one last note about Doppler. That I want to, look at that. Good thing it's time to close. With the Doppler signal, what you want to remember is that your is that your amplitude of the Doppler signal, the brightness of it, is related to the number of red blood cells that are moving that speed. So if you've got AS, for example, you're going to get a bright signal of lower velocity with the continuous wave that identifies the LVOT. And then where the AS is, that high velocity jet is going to be very weak. So it's important, and the sonographers will turn the gain up so that you're seeing those low amplitude, high velocity flow. They'll even turn it up so much that there's a little bit of artifact behind, just so that they know that they've got the peak velocities. So it's probably time for me to stop this one. But as I said, there's just about 3 or 4 more artifact concepts that I'll send the slides, and hopefully you guys can get those. I'll end now.
Thank you, Stephanie, for a great presentation. We have a few questions. In the interest of time, I'm going to ask you just 2 questions that I saw in the chat box.
You bet.
The first one is, what is the difference in slice thickness and side lobe artifact?
That's excellent. And the later in this talk is the slice thickness one. So, but I'll explain it real quick. Side lobe artifacts, the beam comes out the side lobe comes out and it's very contained. So the artifact that you get tends to be something like that band that went across the LV. Slice thickness artifacts are because the beam itself is wide or thick. And so it's picking up part of a wall and displaying it as if it's in the chamber. So those artifacts tend to sort of extend into the chamber from the wall, as opposed to being a band that goes through it. So, and the good thing is we get less slice thickness artifacts with matrix transducers because they have a thinner slice. And when we change the focal zone, it'll change the focus in the slice thickness or elevation plane, and standard transducers can't do that.
Thanks. And the second one is, in attempting to optimize PRF, do you first change the depth followed by adjusting the baseline? And does the order in which this is done matter?
Okay, great. That's an excellent question. So when it comes to PRF, the first thing I would say is you have to put the sample gate where it has to be, right? So you can't really determine the depth. The depth is determined for you by the patient's anatomy. So you get the sample to the depth that it has to be. Once it's there and you're looking at the flow, you can shift the baseline whichever way it needs to be shifted to optimize the flow. And if it's still aliasing, then you change the PRF.
Thank you very much, Stephanie. We have 2 other questions which I will email to you, and then we can post the answers on the website. You can carry on with the second talk whenever you're ready.
Okay, perfect. Let me just pull that up. Okay, so for the next talk, we're going to talk about the normal, transthoracic, and chamber quantification. Now, to try to make this fit in the hour, I'm actually not talking a whole lot about normal transthoracic because I know all of you already know the views and the anatomy and etc. So what I tried to do was to focus a lot on the technical parts of chamber quantification, um, because there's a lot of technical things that go into getting the measurements right. And I want to make sure that you're aware of what those are and looking to see that those are, all correct when you're looking at your measurements. Again, I have no disclosures. So we're going to talk about the different views and identify the standard measurements and potential pitfalls for those measurements in echocardiography. Now, what I want you to know is that I'm going to be demonstrating sort of most, if not all, the possible measurement techniques, um, because this is a board review, but some of these techniques are less desirable options than others. Again, I just think it's important for you to have that broad understanding of what measurements are available. I'm using a lot of images from the ASC guidelines published in 2019. Lead author was Carol Mitchell. These are standardized examples of how to do the measurement techniques. And what I did is I wanted to pull those images and have them in here so there was no question about exactly how the measurements were supposed to be done. And then I've added my own examples in addition to that. There's not time to go over a lot of 3D in detail. I really wanted to focus on the standard, most common measurements that are done and make sure that you understand the proper technique for that. So we're going to talk about long axis, the linear measurements that are done, short axis linear measurements, apical measurements, mostly of area and volume, IVC in the subcostal, and what you can do for aortic arch if you want from the suprasternal notch. This is the link to the paper I was just speaking of, Guidelines for Performing Comprehensive Transthoracic Echocardiography Examination in Adults, recommendations from the ASC. This is a paper that you absolutely must have read and understand and probably bookmark, okay? And the measurement techniques that are published here supersede any previous ones, and some of the techniques have changed. And so you want to be aware of that. Okay, so here's the first recommendation. It has to do with M mode. So routine linear M mode measurements for quantification are not recommended as published in this paper. If they are done, it is noted that they should be done from the long axis. And that's so that you can show that the M mode cursor is going through the minor axis of the LV. If they are done in the short axis, again, it's very important that you're going through the minor axis of the LV. M mode measurements are measured from leading edge to leading edge on the aorta. We'll show that a little bit later. It is recommended and certainly acceptable to do M mode recordings of the mitral valve and the LV for temporal events. They're just talking about not using this for linear measurements. And as you know, M mode for mitral valve prolapse and SAM, etc. And it's also very appropriate, of course, when we do TAPSE. Actually, that's how you do it, right? And with the IVC looking for collapse. So they're not suggesting that it shouldn't be used, just that it shouldn't be used for linear measurements of the LV. All right, so we'll start with the parasternal long axis. And of note, the standard position for the parasternal long axis is usually about the third intercostal space. I mentioned that because in a minute we'll talk about doing aortas. the ascending aorta, and you have to move up a intercostal space, so that would be usually second. So here are the standard measurements from the parasternal long axis. There's the RV, these are linear measurements, excuse me. The RV, okay, that's optional. Some labs do this, some labs do not. I just need to tell you, it's done parallel to where your LV measurement was, and it's inner to inner. So the interface of endocardium to chamber on both sides. Then the interventricular septum, perpendicular to the long axis of the LV diastolic minor axis. This measurement is done just apical to the mitral valve leaflet tips. And once again, perpendicular to the LV, and then the posterior wall. All right. We'll also do the aorta on this, but I'm going to show you that on a different slide that's zoomed up on it. This is an end diastolic measurement on the QRS. Systolic measurement is the LV, again, at the same location that the diastolic one was done, but this one is in systole, and the LA is optional. If the LA linear measurement is done, it's to be perpendicular to the long axis of the LA at the level of the aortic sinuses, and it's leading edge to leading edge, which means it's outside of the LA wall on this side, leading edge of the LA wall to leading edge of the LA wall here. Okay. And then this is a systolic end systolic measurement, typically at the end of the T wave or when the LV is the smallest. So here's just showing that long axis of the LV, and this measurement should be perpendicular to it. That's hard to reproduce, which is why one reason that LA measurement in linear is not as ideal, right? And the other problem is that this measurement assumes that if the LA has enlarged, that it is enlarged equally in all directions like a balloon, but we know that it doesn't do that, and their remodeling can happen. So this measurement has limited value. All right. So here's some pitfalls of the linear AP measurement. These examples come from what I think is a pretty good website that talks about techniques a little bit, and it's called CardioServe. They have a number of different publications, and they reference the ASE, and so I've provided that link. So here's an example where that measurement was not done perpendicular to the long axis of the LA. Rather, it was sort of done parallel to the mitral valve annulus. The other thing from the previous talk, you mentioned slice thickness. So here's a slice thickness artifact. Notice how those echoes are extending up from the wall. And in doing that, you lose the endocardial border, making it hard to know where to measure that. This is a better corrected measurement. The red line is perpendicular to the long axis, and you got out of that slice thickness area. Now, in terms of systolic function and the linear measurements, very limited. Again, this is FYI, because I just don't know if you would have ever had these conversations. So the reason that the linear measurements are less accurate, of course, is that you're only looking at two walls. You're only looking at the mid segment, and the Tycholt's method actually calculates an ejection fraction from this, but it's calculating the volume of the LV without actually having a length measurement. So it's very limited in its value. So with these two linear measurements, LV diastolic and systolic measurements, the instrument could calculate a fractional shortening. I think most labs have that one turned off. that calculation turned off, and then it can calculate an ejection fraction with the Tychel's method. And if you notice right here on this one, it says it's given us an N diastolic volume, and notice it says Tyche, and N systolic volume, Tyche, and then EF. This is an EF that you probably don't want to put as much value in as your method of disc. Okay, but again, it's displayed on the measurement, so I wanted to make sure you were aware of how it got there. If you wondered about fractional shortening is using just the diameter, so it's diastolic minus systolic divided by diastolic to calculate fractional shortening. And again, that is not typically reported. And then here's the Tychel's EF. Okay. Now, the other standard measurements from the parasternal long axis include the aortic root. So in order to see the ascending aorta better, and sometimes just to see the sinotubular junction, we move up one rib space from where the standard parasternal long was. The measurements of the aortic root are done in end diastole. They include the sinuses of Valsalva, the sinotubular junction, and the ascending aorta. All of these are measured leading edge to leading edge. Okay, so leading edge of this aortic wall to the leading edge of this aortic wall. And notice I did not say annulus. If you look at previous publications, we used to measure the annulus in diastole also, but now the annulus is measured in mid-systole, not in diastole. And this brings us to our mid-systolic measurements. We try to zoom on these and notice we're mid-systole, halfway between the QRS and the T wave. So you want to look on the EKG, make sure the timing is right. And these measurements are done inner to inner. So here's the annulus, and the LVOT is anywhere from 3 to 10 millimeters apical to the annulus. Just as a rough note, kind of to remember, the LVOT should range between 1.8 and 2.2 centimeters. If it falls outside of that range, we probably have a little bit of a technical problem on that measurement. And if you're using it to calculate AS, we should really do 3 measurements of that LVOT and look for consistency in those measurements, because that measurement's going to be squared to calculate LVOT flow and calculate aortic valve area. All right. Who knew there was so much to talk about of just parasternal long axis measurements? Now on to short axis. So the short axis measurements that are done involve the RVOT. So we can do a proximal RVOT measurement and a distal RVOT measurement and a main pulmonary artery measurement. These are all done in diastole, at end diastole, okay? Now, what's important to keep in mind with this is that this distal RVOT measurement is not the same measurement as pulmonary artery annulus. And on the equipment, those are 2 different sort of inputs, okay? The reason they're different is this distal RVOT measurement is in diastole. It's a diastolic measurement. If we want to measure the PA annulus to calculate RV stroke volume for QPQS, that has to be a mid-systolic measurement. So those are different measurements. They're at the same location, different timing. Okay, so now moving on to the 4-chamber. This is where the apical window, we're going to have 4 chambers. 3-chamber and 2-chamber. For our measurement purposes, we're really only gonna be talking about the 4 and the 2. Okay. So LA volume measurements. The ASE recommends indexed biplane LA volume measurements. Okay, and the LA volume can be calculated by the equipment using area length method or summation of disk. The ASE prefers method of disk, okay, known as Simpson's method of disk. So here's an example of that. And we've traced the LA. We'll talk about this technique zoomed up here in a little bit, but you have LA end systolic volume in the 4-chamber, 38. And then here's the 2-chamber. So you have LA end systolic volume indexed here at 55, and then the biplane. On this image, the RA and the RV, excuse me, the RA and the LA have been measured on the same 4-chamber. I actually don't really prefer that because usually you have not been able to optimize the size of both of them in one view like that. On your end of your report, it's going to give you that indexed value. If, for example, they're able to get the 4-chamber, but the 2-chamber they can't get because of technically difficult exam, then you're only going to have the 4-chamber. The way the 2-chamber is calculated is simply averaging, the way the biplane is calculated is simply averaging the 4 and the 2 together. So the advantages of LA volume over linear measurements are, as we've discussed, the volume will correct for remodeling. One of the disadvantages is if it can be difficult to get the LA in its full view, and often it may be foreshortened. So we have to be careful about that, and also being able to delineate the endocardium. So we'll kind of talk about that. In terms of the techniques for this LA volume, again, we're going to try to get the 4 and the 2. And we optimize the image in terms of plane and gain. This is a end systolic measurement and not foreshortened, which means it is often not the same plane as your LV measurements. So if you're seeing a lot of images where the LV and the LA are measured at the same time, that's not a technically optimized image. The LV depth should be changed so you're only seeing the LV, and then when you want the LA, it's probably going to be a different plane. We trace the endocardial borders of this. What's super important to remember is that the appendage and the pulmonary veins are not part of the chamber. Those have to be kind of cut off when you do them. Other thing to remember is that the length needs to be displayed perpendicular to the annular plane. And you can see on this image, here's the length. Here's the length. We'll show more about that in a minute. And the length on the 4 and the 2 should be within 5 millimeters of each other. That way, you know that you have optimized the length or the plane in each of those views. Some equipment will be set up that it will not give you a biplanar calculation if they're not within 5 millimeters. And then again, we should use summation of disk, not area length. Just as an example, this is how area length is calculated. This is the equation that's in the machine, okay? The trace looks exactly the same from the sonographer's perspective. It's just the way that it's calculated that is different. It doesn't do as good of a job of addressing remodeling. So here is our preferred method of disk. But actually, the reason I had this in here, This is an older image, so in the report page, it reported LA volume, area length, biplane. Okay, so again, this is just a matter of how the equipment is set up and what it's reporting. This is how summation of disk works. You're probably familiar with this. So when we do the trace, the instrument assumes or does this calculation of the area of a disk and then stacks them up on top of each other. And notice each of these lines where that disk is calculated from is perpendicular to the length. So when we talk about where this length measurement is, it's important that it's perpendicular to the LA long axis, because those disks are always going to be perpendicular to that long axis. So if it's crooked, you get some dead space. All right. Again, these are pretty good measurements and just showing the comparison. So on this side, the 4-chamber is 6.62 centimeters and the 2-chamber is 6.35. So their two lengths are within that 5-millimeter difference, which is what we strive to do. So here's just a chart showing the pitfalls, and then I'm going to show you each one of these. So once again, this is LA volume method of disc. The length needs to be 90 degrees to that LA annular width so that we avoid dead space in the method of disc calculation. The length needs to be in the midpoint of the annulus, and that can be manually changed after we do the trace. We want to make sure the LA is not foreshortened, so it's often not the plane of the LV. The 2-chamber needs to be in a good rotation, so they're within 5 millimeters of each other, and don't include the appendage or pulmonary veins. So again, from this CardioServe website, as I said, it has really good examples of technical problems. This is a good trace where the length is from the middle of the annulus and our method of disc is filling the space. On this one, notice that the length is coming to here. And then when it fills in the method of disc, you see this dead space where the red dot is. So you're missing some calculation of space because of that. So this length should have been moved to here. And then all of these would be lined up and you'd get it filled in. As you can kind of see better on this one. The problem with this one, though, is that we're not in the middle of the annulus. So this one should have been over here. Okay. So that's why I have these in from the article, which are, of course, perfect because they're in the article, but the length is midpoint of the annulus to here, and our method of disc fills the space. And again, within 5 millimeters of each other. This is an example of foreshortening. On many patients, this is what their 4-chamber, well, this is what their 2-chamber looks like. So the LA length is not the same plane as their LV length. So when it comes time to do the 4-chamber LA, you actually need to be back here, which means you're probably not going to have a good LV, but you're going to have a elongated proper LA. And again, this is a foreshortened LA. You can just tell by looking at it, it's too squatty. And you can see the 2 dead spaces on that. Where if this length would have been moved to here, then those dead spaces would have been filled in. All right, and then the 5 millimeter rotation part. So here's an example of a 4-chamber measurement. Now, what's good is the length is in the right spot and we don't have any dead space. All right, but the length is 4.34 And on this 2-chamber, the length is 5.56. So that's a difference of 12 millimeters. So that really should not be used as in a biplane fashion until those two lengths were closer to the same. And then here's an example of the appendage and the pulmonary veins. So in this trace over here, they did a good job of not including the appendage, but they got out into a pulmonary vein. Needs to be just traced here. Okay, so that's a lot of discussion about LA, right? So it needs to be in its true plane, not foreshortened. It needs to be a true 4 and 2, which means their lengths are within 5 millimeters of each other and do not include appendage or pulmonary veins. So now we're going to go on to the LV. All right, the ASC recognizes different approaches to LV volume and estimate of ejection fraction. They recommend biplane summation of disc for volumes. Those are better than, again, our linear measurements. And if available, 3D algorithms for LV volume and function are preferred over method of disc. Now, I'm not including a lot of 3D here because that would make the whole talk too long. And again, if available. So for a board review perspective, feel like you got to really know method of disc well. So that's what we're going to do. So here's your normal 4-chamber view, normal function, and of course, abnormal function. All right, but we'd like some numbers to go with that. So as mentioned, here's the Tyke method, which is not preferred. Here's your method of disc, which we're going to talk about. And then here is 3D, which is beautiful. And we'll be getting more of that as time progresses. So for summation of disc or method of disc or Simpson's rule, whatever you want to call it, we trace the LV in the 4 and the 2 in diastole and systole. These advantages of this over linear measurements are because you have the width, you have the AP, it calculates it assuming an ellipse, and you have a length. The disadvantage is, once again, the image has to be true and not foreshortened. Of course, we'd like to be able to see the endocardium to get a good trace on it. And there can be some errors with shape and with remodeling, especially if it won't fit on the screen. But the biplane helps to address that. Okay. So here are your apical 4s in diastole and systole and 2 in diastole and systole. Notice the depth has been decreased so that we are focusing on the LV. And we try to include a little bit of the LA just so that, you know, you have a reference point for plane. Okay, so again, standard view, zoomed view for the LV function. Again, this is how method of disc is calculated. All right, and so we would like to see that there isn't any dead space in this calculation coming here. So this is an end diastolic volume in the apical 4. And it does give you the length. Now, in terms of the way this trace is done from a technical aspect, you can do it as an ellipse that comes in that you then shift, or you can do an actual manual hand trace. Either way, we start at the annulus and then go up to the apex for that. That trace should be in that the compact myocardium is what you're tracing on top of. So the non-compacted myocardium, your trace is going through that. It's going through the papillary muscles, not around them. Okay. And then the instrument will calculate and report the EFs. It will report them for each view, and then it will report the biplane. Now, you'll hear, sometimes there's a discussion about comparing the 4 and the 2 EF and looking at those to see if we think we're accurate. Okay, if it looks like the patient has global dysfunction, then yes, the 4-chamber and the 2-chamber EF should be roughly the same. But if they have wall motion abnormalities that are regional, then of course, those are not going to be the same. So you just have to kind of think about, and the numbers should make sense for what you're subjectively seeing. The diastolic and systolic measurements need to be on the same beat. And of course, if they are not in normal sinus rhythm, we would try to get a normal beat on those patients. And then, as I mentioned, we measure through the papillary muscles. And so all of these are examples of, good measurements coming across the annulus, no dead space, nice length. Now, the next thing is these pitfalls. So trabeculations and pap muscles, we measure through them. They are not considered part. They should be considered part of the chamber, not of the wall. Don't foreshorten. And if, from a technical aspect, if the LV is foreshortened, it usually means that we need to move one intercostal space more inferior to try to get that true long plane, long axis of it. The length should be 90 degrees to the base at the annulus so that we don't get that dead space in the calculation. And in order to make sure we're on axis between the 4 and the 2, the difference in those two lengths should be less than 10%. So here's some examples of problems. So this one is done correctly. The measurement, went through this trabeculation or papillary muscle, and it went around, right? As we would want this one, they went out around, and this is incorrect. So this trace should have been here. This is an example of foreshortening. So if you're in a true plane, the LV is nice and elongated. And if we're foreshortened, it just looks obviously shorter, like this one. So in this example, we really needed to come down one intercostal space if possible, so that we're getting a better systolic image. All right, and then here's the example of that dead space when there's too much angle between here. So on this example, we're doing really good in terms of not having that dead space. And the reason is that this length is closer to 90 degrees to our annulus starting point. It's not exactly 90, but it's closer. All right. Here is just to talk about the pitfalls of being off axis or in axis. So in our 4-chamber, the length is 7.73. And in the 2-chamber, the length is 7.52. So we are within that acceptable range of 10%. Okay, so about LV volumes and ejection, LV volumes are indexed to BSA. You can look up the numbers yourself and you probably already know them. I have them listed here, and then ejection fractions as well. So now to move on to the RV side, the RV measurements are more challenging to get. And something that's super important is that these are done in what's called a RV focused view, not modified view. This is an RV focused view. It is literally the same RV plane, just shifting a little bit so you can see the RV free wall. And these are end diastolic measurements. And what we're going to want is the minor axis at the level of the base, mid ventricle, which is at the roughly the level of the LV papillary muscle. And then we're going to want a length, as you can see here. Okay, so these are like perfect measurements. They are really hard to get. Here's another example. So again, it's a RV focus view. So it's the same four chamber. The left ventricle is kind of cut off the screen so you can see the right ventricle, base, mid, and length. We can also do a trace of this. It's the same view, RV focus view. We've done a trace, and by doing the trace, we can calculate the area. If we do an end diastolic trace and an end systolic trace, that will give us fractional area change of the RV. Now, be sure to note, we can't do an ejection fraction of the RV because there's no way to get a second, well, I shouldn't say that. We can with 3D. With 2D imaging, we can't get an EF because there's no way to get a two chamber on the RV like we can on the LV. So we can only do the four chamber trace, and that'll give us a fractional area change. And then we have the RA measurements. These are done in end systole, just like the LA ones. As I mentioned, not necessarily in the same image because you want to optimize the image to the true size of the RA, usually not in the same plane as the LA. And you're going to do the same type of trace, the same things apply. You don't want any dead space with that method of disc analysis, and it's just the chamber. Don't go out into the into SBC or anything. Okay, and then lastly, I wanted to talk about the subcostal IVC and possibly aortic views. So the long axis of the IVC, we're of course looking for normal collapse. In terms of the aorta, we don't routinely measure it, but if it was aneurysmal, we would of course want to measure that. These would be linear measurements. So the linear measurement of the IVC is just proximal to the IVC aortic junction. Normal is less than or equal to 1.2 centimeters. And this is measured in expiration in order to get it at its maximum size. And then, as you know, with the sniff, it should decrease by 50% or more. So here's our sniff. And these are the measurements that went along with that. So here's the expiration and inspiration measurements. Sometimes we really like to put an M mode on so that we can show that change. Something I want to point out that you make sure to know, you really shouldn't report the IVC diameter from this M mode measurement because notice we are not in the minor axis. It's almost always going to be off axis because the IVC is, at an angle. So don't report this as the size. Report the 2D measurement as the size because we'll be sure to get the 2D measurement in the minor axis. Here's of course IVC plethora where it's dilated and not going to collapse. Now, measurements of the aortic arch are not routinely done, but I wanted to mention them in the event that we need to do them, maybe because of a co-arc or something. So you have the aortic arch long axis view coming here. If they only all looked like that, beautiful. And oh, go back. So in terms of the measurements, we would have already done the ascending down here from the peristernal long axis. So you can do an arch measurement, you can do an isthmus measurement, and you could do a descending if you can see it. Those are all end diastolic measurements. They are more difficult to see caliper placement because we're not perpendicular to these walls, but it's supposed to be an outer to inner or leading edge to leading edge as before. And again, where it can be helpful is because if you do have a situation of a co-arc, you can try to estimate some kind of size, particularly if the co-arc is a long area of narrowing. You're not going to get the velocity increase from Bernoulli's equation. This one was a focal area of narrowing, so we had a nice velocity increase here. But a long area of narrowing, you're not going to get that. So you're going to get better information, but really by looking at the 2D and seeing how narrow it actually gets. So this one I went short. So actually this might be helpful. I have more time for questions and I can go back to the other one if we need to. So, so hopefully this was helpful to you just to understand how the measurements that you're getting when you're reading an exam, how those were done and what the specifics, details about how they're supposed to be done, timing, location of caliper placement, limitations versus advantages of different measurements. So how about questions?
Thank you, Stephanie, for an excellent talk. We have two questions in the chat box. The first one is, what are your thoughts on the LVOT being proportional to the body surface area? Not sure if there is any validity in this.
Repeat that.
What are your thoughts on the LVOT being proportional to the body surface area?
Oh, okay. Very good question. So I don't know of the validity of that. And there might be some others listening in who can kind of comment on that. This is the one thing I would say. That measurement is so critical for the continuity equation because we're going to square it, that I think that it's super important that we just make sure that the measurement is correct. And I think the best way to do that is, number one, you really have to check the timing and you have to, be zoomed like we should, and check the location of that measurement, that it's not too far away from the valve. It should be right at half a centimeter. And if you start getting further away than that, of course, it's going to be bigger.
Okay, and the second question is, why is LVOT measured in mid-systole and distal RVOT measured in diastole?
Okay, perfect. So the LVOT measurement that we're using, the reason we're using it is to calculate LV stroke volume. So we want it as a mid-systolic measurement as the average size. So then when we do the pulse wave trace for TVI, we get stroke volume throughout systole. When we want to get stroke volume for the pulmonary artery for RV stroke volume, we do the RVOT in mid-systole. So that is a different measurement than what I talked about today. That's a mid-systolic measurement. And again, we trace the pulse wave of the RVOT to get RV stroke volume. That's for QPQS. If we're measuring the RVOT and the distal RVOT simply for size, then those are diastolic measurements because they're simply for size. Is this aneurysmal or not aneurysmal? I hope that answered the question.
And the third one is, what is the difference between an RV focused view and a modified RV view?
Oh, very good. I'm sorry I didn't show you an RV modified. Let me find one. An RV modified view is when we've angled such that we're really optimizing the flow through the tricuspid valve. And so it's not in the right plane. Let me find one. Okay. I'm pulling up a different a different slideshow, so you're going to see me kind of going through it. Let's see where to go. Okay. So TAPSE is also done in an RV focus view. So if you look at this image, the RV and its size proportional to the LV, it looks like a 4-chamber, and we're going through that. That's an RV focus view. And this is an RV focus view. Beautiful. And that's where you get the best TAPSE analysis. This is a modified. So you see how the RV is opened up, and this is angling from the 4-chamber. It's angling a little bit anterior. So you're seeing more of the anterior wall, and you've got the tricuspid valve opened up. This is the view that we often need to get into to get better TR. So this is a modified RV. And notice you don't get as good a TAPSE on that either. So you really shouldn't do TAPSE in the modified. Guess I don't have it as a clip, sorry. I hope that helped answer it.
Yes, thank you, Stephanie. And just a follow-up question which just came in for the first question, which was the LVOT being proportional to the body surface area. The question is, you had mentioned that the LVOT diameter should be between 1.8 to 2.2, but what if someone has a body surface area of 2.7 and their LVOT diameter is larger? Then what do you do in those cases?
Yeah, that's getting back to that other question as to whether or not the LVOT is indexed. Here is the bottom line about that LVOT measurement. That LVOT measurement is going to be used primarily for stroke volume. So if, I think there needs to be more study on this, but at the end of the day, if you're calculating stroke volume through the LVOT, if the LVOT stayed, and it's a patient with a larger, a larger BSA, like 2.7. So in that patient, if their LVOT has remained, let's say, quote, normal in size, then the volume through that LVOT, the velocity is going to be higher in order to account for volume. In a patient with the 2.7 BSA, if their LVOT has dilated, then it's likely that their velocity through the LVOT is back down at normal, so their volume is higher, but it's higher because of diameter. So at the end of the day, that's why theoretically the continuity equation should work to calculate aortic valve area, because either way, you're calculating volume through the LVOT either by an increased area and a normal velocity, or a normal area and a higher velocity. I hope that made sense.
Yes, thank you, Stephanie. We still have 10 minutes in case if you want to finish the first one. If not, then that's
Yeah.
perfectly fine.
No, I would be happy to if everyone's happy with that. Although, I mean, I'll go a little bit. If people need to sign off and take a break, that's fine too. But no, let me open up my other one and finish. Okay. So another case, going back to our physics talk, the question being, as often is the case, is there apical thrombus or not? So often we want to sort of think about contrast. I just want you to think about the things that we need to do for 2D adjustments first before we go to contrast or imaging enhancing agents. And those 2D adjustments include the following. So here's our standard 4. The first thing that we should do is to move the focal zone up to the apex. So see, as I move the focal zone up, right away, we get better information about that apex. So that's number 1. The next thing that we can do is we can put on some type of colorization. You know, I picked septa. There's all kinds. There's rainbow and everything else. So our eyes, our human eyes are a little bit better at seeing color than 2D. So this can be helpful. And then lastly, if you notice, I even decreased the depth more here, and we're on the apex, and the focal zone is here, but I also changed the frequency. Okay, I went from penetration, which is a low frequency mode, to resolution, which is the high frequency mode, because I'm only looking at this much information. So I don't need to penetrate all the way through the heart. I just need to focus on the apex at this point, and that will help with that resolution and sorting that out. If after doing those things, there's still a question of thrombus, then imaging enhancement agents should be used. And that's a whole discussion, you know, about when to use those. But I wanted to note that there are 2D things that should be done as well to see that area better routinely. So here is that near field artifact, okay? And then with contrast. A couple of things about contrast without having a full contrast talk. This one, they have moved the focal zone up, but this one was done a few years ago. We try to keep the focal zone down here when we put contrast in. And the reason for that is because if you move the focal zone up, you're going to pop all your bubbles, and the contrast isn't going to last as long, and it's not going to fill well into that apex. So typically we keep the focus down. I just point that out because in the previous slide, I'm telling you about moving the focus up. So that is true until you push the contrast, and then we move it back down. And then here's a true thrombus that I thought I'd throw in here, but notice we've decreased the depth and we've moved the focal zone up. The focal zone traditionally is about at the level of the mitral valve, and we just moved it up. Okay, here's a question. Is there left atrial appendage thrombus. What is happening here? All right, this is the beam width or slice thickness artifact that we had the question about. So the elevation plane is picking up echoes that are adjacent to the appendage and placing them as if they're in the scan plane. So what are you going to do for this? You always need to see things in two planes. So, you know, on this, going into the biplane mode can be helpful. With that, I mentioned that with our matrix transducers that we have now, this slice thickness is much thinner than it used to be. So that elevation resolution is better than it used to be. But this is an example of showing how this is working. So here's your, on a standard transducer, if you look at the beam this way, that's the beam width. That changes when we change our focal zone, but the slice thickness doesn't change, it's fixed. But on a matrix transducer, when we move the focal zone up and down, it changes the beam width location, the narrowest, and it also changes the slice thickness. So it focuses it in both ways. So that's why it gets better. But slice thickness artifact, if you have any trouble understanding what that is, if you're also familiar with reading, say, CTs, it's the same thing as partial volume in a CT, if that's helpful for you. So we have a structure that is outside the primary beam, and the beam is picking it up and displaying it as if it's in the beam. This is one example. I don't know if it's the greatest, but this is a short axis with the PA coming and bifurcating. And it's looking like there's turbulence in the left pulmonary artery. But actually that's turbulence in their LA that's being sort of picked up and displayed as if it's in the pulmonary artery. This is maybe a better one on this TEE. This is the slice thickness artifact coming into the aorta. So before, when I showed you the grading lobe, it was a band that just kind of randomly went through a chamber. This slice thickness extends from something. So it's like the wall here being extended and displayed into the vessel. On this one, you can see something seems to sort of be popping into the LA here, but this is actually anatomy outside of the LA, and it's just being picked up by that slice thickness. Now, this is a matrix transducer, and if you notice, we've moved the focus all the way up to here because we were thinking there might be thrombus there. By doing that, that makes the resolution down here worse. So if we would move this back down to where it was, that's going to narrow that slice thickness, and this artifact's going to lessen. And this case is refraction. So refraction is the change in direction, oh, I'm almost done, of the beam. And this is going to happen a fair amount on the subcostals because when we go through the rectus muscle, there's often refraction that happens. If you look at this, it's a short axis subcostal. Here is the aorta, RA and RVOT, but it's mirrored over here too. So there's a mirror this way. That's a refraction artifact. So it's a mirror image horizontally. And here is this refraction. This beam went straight. This one came out at an angle. So when the beam comes out at an angle, whatever it's hitting is going to be displayed as if it was in the primary beam. Edge shadow artifacts that you see are from refraction. And those are the only examples I have of that. So again, I highly recommend this journal article for artifacts and the ASC article from 2019 for standard technique and measurements.
Thank you very much, Stephanie, for two phenomenal talks. I'll have Dr. Ashwat take over.
Okay.
Dr. Smer, you can start sharing your screen in the meanwhile.
Thank you very much, Stephanie, for those two exciting talks. Very, very informative and high yield on the boards. A lot of physics questions. So thank you very much for doing those. Really appreciate your contribution. I'm going to move on and introduce our next speaker, Dr. Ayman Smer. Dr. Smer graduated from the University of Tripoli, Libya, and he completed internal medicine residency and cardiology fellowship at the Creighton University School of Medicine in Omaha, Nebraska. And he now serves as an associate professor at the School of Medicine and a faculty at the Cardiology Fellowship Program at Creighton University Medical Center, Nebraska. He is passionate about teaching and is a dedicated educator. His research interest is in quality improvement, atrial fibrillation, and in 3D echo. Eamon is the father of three boys, his little monsters, he calls them. Pre-COVID, he loved to travel and enjoy playing soccer, but as we know, COVID changed our lives. So nowadays, he spends most of his time on his phone and plays PlayStation with his boys. Eamon was one of our speakers last year, and we really appreciate his contribution to the lecture series. Over to you, Eamon. I think you're muted.
Okay, thank you, Dr. Ashwood, for the invitation. Good morning, everyone. And I wish blessing and happy Ramadan to all Muslim fellow with us today. It's great to be here with you again for this year, for this successful program. So I'd like to thank the Iowa ACC chapter and Dr. Ashwood, Jay, everyone in the team, Dr. Roy. Today I'll be happy to talk to you about 3D echocardiography. My only disclosure today that I cannot make you expert in 3D in 1 hour, but I'll do my best to go over important concept for 3D echocardiography. We'll talk about the concept of 3D imaging. We'll talk about a common clinical application of 3D echocardiography and the 3D image acquisition and optimization. So we'll do some practical maneuver, how to obtain a nice 3D image that will help you make a good clinical decision when you manage a patient with heart disease. So the heart, this amazing organ, the perfect pump that we all here fall in love with, every one of us see it in a different perspective. For an echocardiographer, they see it through the grayscale with two-dimensional echocardiography. If you talk to interventionists about the heart, they will see the coronary arteries. If you talk about the heart with the electrophysiologist, it's all about electricity, the conduction, how it's fast goes from the sinus node to the Hesperkinji system, where that BVC comes from. They get really excited about that. And if you talk with the pathologist, they see it aftermath and they get excited writing a report about the case of cardiac sarcoid that got missed, the hypertrophic cardiomyopathy of a young kid with the hypertrophic cardiomyopathy or cardiac amyloidosis. If you talk to the surgeon, they see it differently. They hold the heart every day in the OR. So the surgeon have better understanding to the heart anatomy than us, because as I said, they see it every day, they open it, they touch it. With the 3D echocardiography, okay, we have some technical difficulty here, sorry about that. Okay, my slide has a lot of videos, so let me start over again. Sorry about that. Okay. Trying to log in again here. I restarted my presentation again. Sorry about that. Here we go. Can you guys see my presentation now?
Yes, we can now.
Okay, sorry about that. So I was saying every one of us see the heart from a different perspective. It depends on your subspecialty. And for us now, with the development of echocardiography, the 3D echocardiography, we can see the heart the same way the pathologists see it without going to the morgue. We can see every single detail in that heart. For example, look at this biatrial panoramic view on the left here of the heart. You can see all the trigone with all four valve very nicely with every single detail. It's identical to an anatomic structure on the right here. We can see the heart the same way a surgeon see it without going to the OR. For example, if you look at this image of 3D of the mitral valve, the left atrial view, the surgeon view, you can see the mitral valve is obviously myxomatous. You can see the P1 with the torn cord flail leaflet. That's what the surgeon sees in the OR. And the surgeon, they like 3D because it makes sense to them. It's like exactly what they see in the OR. So they like that. So how we get there? This is all start in the early 1950, and thanks to these two gentlemen, Dr. Elder, a Swedish cardiologist on the left here, and Dr. Karl Hertz, a German physicist, teamed up and they gave us the world first echocardiography. They called, and this is their first ultrasound machine, they called ultrasound cardiography. They presented this at the Third European Congress of Cardiology in Rome in 1960. The first application of cardiac ultrasound started with the A mode, when you have an ultrasound probe that sends a signal to the cardiac structure, and that signal comes back as an amplitude, and we record that amplitude. And by changing the spike to a dot, okay, and the frequency or the amplitude of that frequency into a brightness, we get into the B mode, which stands for brightness mode. And when you add a time component dimension to it, you end up with the M mode, the motion mode, and we're all familiar with that. And in early 1970, the grayscale concept came in, and we start having the two-dimensional echocardiography. In early 2000, we were able to finally use a 3D imaging technique to view a 3D structure, the heart. And we have a 3D echocardiography. If you look at this piece of art, so here, to take you a tour in this view. So this is interior, this is medial, posterior, and lateral. This is the left atrial view, in-face view of the mitral valve from the left atrial perspective, also known as the surgeon view. When you have your aortic valve at the 12 o'clock, this is the interior mitral leaflet because it's interior close to the aortic valve. This is the posterior leaflet. You have the coronary sinus going down here. At 9 o'clock, it depends on patient anatomy, between 9 and 11 o'clock, you will have your left atrial appendage. So how we get there? The concept of 3D echocardiography is not new. It's since 1960s. Okay, but with the recent advancement in the software and hardware, we were able to transform that theory into reality. And that goes back to having a new generation of piezoelectrical crystals. We call them the pure wave crystals, and having the microelectron to put them on a small footprint on the echocardiography probe. So talking about the new generation crystals, I'm going to show you this pictures diagram, explain to you the difference between the old conventional ceramic piezoelectric crystals compared to the pure wave crystals. So if you look here on the left, this is how the crystals look like, unbold, with no electricity going through them. There's no clear directionality in the flow. Once you emit electricity to emit ultrasound beam, you can see some directionality in one direction. When you look at the pure wave crystals, the BMT, the BMN crystals, you can see with unpulled, no electricity, like there is no boundaries. Okay, again, the directionality is not that clear. Okay, but there's no boundary. It's very homogeneous. Once you put an electricity on that crystals, you can see you get like very uniform direction. So that's allow us to direct our beam the way we would like to see it goes to. If this is a microscopic pictures of these crystals. So on the left, this like your ceramic conventional crystals, you can see clear boundary, you can tell there's a clear direction. And if you look at the pure wave crystals, it's very homogeneous, almost perfect in uniformity in direction. So this allowed us to be able to acquire 3D imaging because the ultrasound beam, we can control where it goes and where it come back. The computer technology has helped us as well because we were able to condense or compress, like for example, 150 microelectron that carries between 2,500 to 3,000 of those microcrystals into small footprint to the transthoracic and transesophageal and thoracic echocardiogram. And by putting these crystals on those microelectron, we developed what we call the matrix array ultrasound. The matrix array ultrasound is an important milestone in the history of 3D echocardiography. So this is how the matrix array ultrasound it looks like. The operating frequency between 2 to 4 for megahertz for transthoracic, and between 5 and 7 megahertz for the transesophageal echocardiogram. So here, as I said, this is your probe. You have your crystal embedded in those micro electrons between 2,500, 3,000 element in it. And once you emit an ultrasound beam, you're going to send a pyramid shape ultrasound beam to acquire the data. And I want to explain to you the difference between 2D and 3D here. So the depth of the image and the elevation, I think Stephanie explained that very nicely in the previous lectures, it's what you have in the 2D. But what makes 3D is different and unique is that we add the lateral width into that beam. So we can acquire more volume, large data set every single second. So if you apply into that to practice, so this, for example, 3D full volume of transthoracic echocardiogram, 4-chamber view. So this is your raw data. You see the pyramids, okay, large data, then you crop it to clean it out. You can get your region of interest. And this is just kind of anatomic explanation to what you're seeing here. Now, the 3D probe, besides it's like a matrix array that has those micro crystals and microelectrons, it has all the conventional modality of 2D echo. It has the MO, it has the grayscale with 2D imaging, it has pulsed wave, continuous wave, and color Doppler. What make 3D probe also unique is the option of biplane or X-plane, and I think this is underused. It does decrease your frame rate, but it can give you a lot of information. You can have more efficient study. And sometimes when we, in clinical practice, we struggle on obtaining some views. For example, if you try to get that 135 view of the left atrial appendage, if you find that appendage in your 145 degree by using your biplane, you can open the 135 degree without having dial out all the way to 135 degrees. So that's something I'd recommend that you start using the biplane option. In regards to the clinical application of 3D echocardiography, chamber quantification, it's evolving. We're getting more robust data on the use of 3D in terms of accuracy and reproducibility. And I will show you some data. Valvular heart disease, that's unique use of 3D echocardiography, both for native and prosthetic valve. I'm going to show you a couple of examples. Intracardiac masses are also important use of 3D echocardiography, as well as for congenital heart defect, and that helps us for the assessment of the size of the site of the defect, the size, and chamber quantification, and also help us by using live 3D for procedural guidance. As you all know, the interventional structural heart disease field has evolved in the last 10 years, and 3D echo is a very integral component in that regard. For TAVR, we all know that CT has won this battle, but in some cases we still use 3D echocardiography. Mitral crib and left atrial appendage occlusion devices, we rely heavily on the use of 3D echocardiography. Stress echocardiography, it's also evolving field. There's some limitation due to the frame rate and the timbre resolution, but it's something I expect in the next few years, we're gonna see it more practical, because if you think about it, in one beat, you can assess, for example, if you're doing the short axis, you can assess the basal, mid, and apical view, and a short axis. And with your apical view, you can get your 2-chamber, 4-chamber, as well as a apical 3-chamber, just if you scan the patient twice. So it's very exciting to see how that field evolving by the development of the technology. Now, in terms of when we talk about the chamber quantification and function, we all know that the 2D image, most of the time we use the visual assessment. Simpson's method it's more objective, but most of us, we use the subjective method. We all know when the ejection fraction is normal or low, there's no much diagnostic dilemma. We all agree on that. It's when we have that 30, 40, or low 50 range, then we all struggle with. And I cannot tell you a personal experience. When I was a fellow, I was reading with my mentor. He was like the echo guru in our lab at Creighton, and we looked at echo that we both felt that ejection fraction is around 40, 45% at the most. Then we looked at 3 months ago to compare the previous echo, and we saw that the report says the EF is 30, 35%. There's some change. So we looked at the images from 3 months ago, and we said, oh, we looked at each other, we said, there is no way this ejection fraction 30, 35%. This is like 40, 45, like the one we saw today. So my attending doc, he told me like, hey, look at the report. Who did the study? Because some of us, they have a more tendency to undercall it. So I looked at the report 3 months ago, and it was him and me. The two-person, just different timing, give different reading. And that's what all you guys know, the intra-observer variability. And there's large inter-observer variability with the 2D echo up to 10%, which is significant, right? We decide on patient getting an IC defibrillator if the EF is 35%, so a 10% difference, it can make a big change in the patient life. It's also experience dependent. Now, what 3D echocardiography add to that? It avoid the geometric assumption. As we know, when we do the 2D, we have some assumption that the heart has like certain shape, elliptical or rounded. The 3D also, we avoid the foreshortening, okay, because we get the larger area, we can open the left ventricle as much as we can. Relatively, it's reproducible, and it has excellent correlation with the CMR, cardiac MRI. It's still, for the volumetric assessment, it's underestimate the volume, and that mainly because of we include the trabeculation. The 3D echo is not as good of delineation of the trabeculation compared to the CMR. So that's the main difference, that the 3D echocardiography, it's a reliable way to assess the left ventricular volumetric, like in terms of ejection fraction, but still underestimate the volume when you compare to MR, because that trabeculation that we usually include with that. It also provide us with accurate assessment for regional wall motion abnormality. For this is automated view, 3D volumetric assessment and wall motion for the apical 4-chamber view. And you can see, we can look at how every segment is changed during systole and diastole. This is your volume assessment. There's different types how we can assess the ejection fraction. Some of them are tracing. This is the one that's less accurate, and the one volumetric by using the volume. And we can lately we have the heart model. Some of the vendor, what they created, an automated 3D transthoracic echocardiogram of the left heart chamber, the LV and RRA. They work on the RV, but right now it's for public, for the commercial for the LV and RA. And why? And the concept of that we feed the computer with a library of thousands of 3D data sets of different heart morphology, banana shape, normal heart, dilated heart, sigmoid heart. And we teach the computer, and computer learn that how to apply that on the heart that you scan. And by doing that, in a few seconds, you can generate volume in systolic and diastolic volume with ejection fraction. It's early to judge, but there's some data showing this is very correlated to CMR, so it's a promising field. And what's unique about it, it's practical because it's automated, so you don't have to do much maneuver or changes because it knows different type of heart, and it will put that patient's heart shape in what fits with their database. But it has to be filled with thousands of 3D data sets. The other thing too, for the 3D echo has advantage for LV mass as well. Compare this on the top here with the green. This is how we assess the 3D, the LV mass using 2D echocardiography. And at the bottom here, how we use 3D echocardiography for the LV mass. When we convert to the gold standard with the cardiac MRI, you can see here in this diagram that the 3D method for assessment of LV mass is very comparable to the CMR compared to 2D. So obviously 3D is superior to 2D for LV mass. And also we can use the 3D echo for assessment of 1 second, lost 1 second. For the left atrial appendage, for left atrium sizing. For some reason, I lost the slide. Anyway, now when we talk about valvular heart disease, assessment of mitral valve anatomy is very, very valuable by using 3D echocardiography. As you know, mitral valve is very complex anatomy. It's very complex 3D structures, and using the 2D technique, it has a lot of limitation and we can miss. For example, I'm going to show you this case here, and I'll let you take a look at it for a few seconds here. And again, this is, just take you a tour. This is a left atrial view of the mitral valve in FOS view. This is from the left atrial perspective, the surgeon view, and this is from the LV perspective. That's the anterior leaflet, the LVOT is here, and that's the aortic valve. So you can see here in this patient, there is a cleft at the anterior mitral valve leaflet that it's very difficult, even with expert cardiologist and imager, to diagnose that with the 2D echocardiography. And 3D allow us to pick up more of these cases that they come with severe, moderate to severe MR. When you do your transthoracic and transesophageal, you can't pinpoint a certain defect, but just by one single image, 3D zoom, for example, in this case, you can easily appreciate this defect, the cleft in the mitral leaflet. Of course, when you see a drop off, it's not enough. You had to add color to it to see the regurgitant volume. So keep that in mind, because 3D has a limitation with the dropout phenomena. Now, for also assessment of the aortic valve annulus and LVOT, as I said, CT scan is the gold standard for doing that, but we still, in some cases, we can use it to assess the aortic annulus and the LVOT area. Another assessment for 3D, as you know, the planimetry is not recommended with the 2D echocardiography because it's hard to tell if you're at the tip of the leaflet, but because of the multi-plan reconstruction of 3D, we can assess accurately the mitral and the aortic valve area using planimetry. So here with the multi-plan reconstruction, when you look at the mitral valve area here, different perspective, you can find out where is the tip of the leaflet and you measure your mitral valve area. The only limitation for using the planimetry with 3D, sometimes because of the calcium reverberation, when you have a heavy calcified mitral, or especially with aortic valve, that reverberation will make it difficult to accurately trace the planimetry area. So keep that in mind. Regurgitant orifice measurement via vena contracta for regurgitant lesion is another advantage for 3D echocardiography with color. Still, we don't have a gold standard method like for reference but it's very valuable, and it helps us accurately assess the orifice area, because right now we're using the 2D image and the BISA, we assume it's surrounded orifice, right? And what 3D showed us, I'm going to show you an example next few slides, that it's not oval, it's not rounded all the case. Sometimes it's elliptical, satellite. I'll show you some example. Another invaluable use for 3D echo, especially with color, is the assessment of prostatic valve malfunction and paravalvular leak. It's invaluable. It saves you a lot of time and effort and help us guide any interventional procedure for those patients. So here I'm gonna share with you an interesting case. I want to get your opinion. We have questions, so I'll give you a few seconds to take a look. This is a 54-year-old gentleman present with new onset atrial fibrillation. On exam, had loud holosystolic murmur at the apex radiated to the axilla, grade 3/6. And this is his transesophageal four-chamber view. You can see here, this is the LV, left atrium, right ventricle. I'm hoping you guys can see the image clearly. I'm gonna stop it. This is the 60-degree view mid-esophageal here, anterior wall, and this is the inferior wall. Okay. At the bottom left here, this is a 90-degree. You can see the anterior wall, the appendage here, and the mitral valve leaflet. And the last one here, the 125 long axis view of mid-esophageal. You can see the aortic valve here, and this is the mitral leaflet. This is the anterior septum, the RVOT flow tract here. So I'm gonna play it for a few seconds, and Jay is gonna help us. We have a question. I'll show you one couple of slides. And I want you to give me what's your diagnosis. So now here, adding color, of course, a lot of you want to see a color. Obviously, you can see their eccentric MR jet hitting the lateral wall of the left atrium and the posterior wall of the left atrium here. Jay, can we have the poll question? Okay, so what's your diagnosis? Severe MR due to P2 prolapse. This is a severe MR due to flail P2, or this is severe MR due to A2 prolapse, or severe MR due to flail A2. So far, we have only 36. Okay, more. If you guys, yep. Okay, someone asked, can see the video again. I'm not sure if I'm allowed to do that while the pool is on, but I can go back after that. Okay, so almost half of you answered. Hey guys, let's get it done. Okay, so we have a kind of different answers. Bell shape, 23% of you think this is severe MR due to P2 prolapse. 19% they think it's severe MR due to P2. So there's like half and half. Half they think it's posterior leaflet, half they think it's anterior leaflet, and the same thing, the half think it's prolapse, the other half think it's flail leaflet. Okay, good to do that. So now what I'm gonna do, I'm gonna show you one. So far I showed you 6 clips for this patient, right? 6 clips for 1, 2, 3, and play it again for you here, because some people ask to see it again. So I'll leave it playing for a few seconds. Okay, I think that's enough. I know sometimes with Zoom doesn't go as fast as we would like to see. These the other 2, so we have 6 images with color. Now what I'm going to show you, I'm going to show you one left atrial emphos view of the mitral valve, just one clip for the mitral valve, the same patient we looked at, and I'll ask you the same question again. Take a look at it, and you tell me what do you think wrong with this patient. And Jay, whenever you can get the same question again. So remember, this is the emphysio, the left atrial appendage. This is the aortic valve. So this is anterior, and this is posterior here. Okay, we have 51 responses so far out of 95. We need more responses. Come on, guys. Okay, I think we'll take that. Okay, so at least now more people feel this is A2 problem, right? Most of us, they don't think this is B2 anymore. And now the conflict or there's the disagreement with is the prolapse of a leaflet. So here I'm going to show you right now. Now, if you look here, this is the aortic valve. So this is anterior, medial, lateral, posterior. And if you can see here, the whole interior leaflet, the whole here is prolapsing and myxomatous. And you can see here that that's a torn cord. That's the torn cord, so flail. And the tip of the cord point toward the left atrium. So that's a flail A2. Now they said like the myxomatous mitral valve, the disease that give you the fingers. It has the torn cord. So if you look at that, it's like someone giving you the finger here. Excuse my French. So again, I'm going to play it again. You can see there's a mitral leaf, the whole interior leaflet, mainly the A2. Okay, it's myxomatous prolapsing with a torn cord here. So the point I'm trying to make here, we needed 6 clips to look at this patient, and we weren't sure that this is a posterior leaflet or anterior leaflet. And now with just one clip of the 3D of the mitral valve, our confidence in the diagnosis got much better. We have more information. We can see why some of us think this is a posterior leaflet, right? Because if you look at with your 4-chamber, 2-chamber, if you cross it here, it falls into the posterior leaflet, but because the anterior is too big, and that's what we got there. So there's a reason for that. It makes sense. The same example I show you with the mitral cleft. Some things you cannot see with 2D, but you can easily appreciate with the 3D echocardiography. This was one of the first cases I saw after I graduated from my fellowship at Creighton. So it's an interesting case for me. Now, let's give you another example, and we'll talk about more 3D color here. So we have a 71-year-old gentleman with severe mitral regurgitation due to MSSA endocarditis. He underwent bioprosthetic mitral valve replacement, and a few months later came back with another bacteremia and heart failure symptoms. So this is a zoom view of his mitral prosthetic valve. If anyone can appreciate anything, I'll show you. This is another view, 125 degree. This is the aortic valve. This is the prosthetic. On the chat box, does anyone have a thought? What do you think going on? Okay. Okay, let's see. Some people have some responses. MS, mitral stenosis. Okay. I'm not sure about that, but pay attention to the color. Pay attention to the color. Remember, with the mitral stenosis, you want to look at for more spectra, right? PW, CW, more than color. With color, you look for more valve adhesions. Okay, good point. Okay, who does think there's better? Exactly, yeah, excellent. Some people, they say valvular adhesions, valvular and valvular leak. Excellent. So you can see here, I'm going to stop these 2 images. I'm going to start again slowly here. You can see there's some flow going back here, but we're not sure if it's intravalvular or bivalvular. Remember, this is a new valve, so you shouldn't see much tissue valve. You shouldn't see much valvular regurgitation here. Play more, you can see some width around. There's one here at 3 o'clock, another one here, 12 o'clock, another one here. This one is not clear if it's valvular or perivalvular. Now, when you look at the images on the right here, I'll show you slowly. You can see, start seeing more color going here. 1, 2, 3, 4. Okay. But it's hard to tell how severe is this, right? On these 2 views. Now, let me show you the same patient with 3D color, full volume 3D color. And this is the prosthetic. I'm going to stop it. So I'm going to give you a tour quickly here in this image. This is the annulus of this bioprosthetic mitral valve. And this is periannular. Can you see here? There's 1, 2, 3, paravalvular leak, significant jet. If you do the vena contracta for each one of the blossom, this patient has a severe paravalvular leak. And here with the multiple reconstruction images, you can see some of the jet even hitting toward the left atrial appendage, and we can assist the vena contracta of that. So this is an important use for 3D color for patient with prostatic valve, especially when looking for a valvular leak. Some of you have astute observation that this patient has valve dehiscence. We can see here there's drop off, but this is not enough. You can see the valve motion is rocking, and you need to add color here to look for regurgitation. Otherwise, just the drop off, it doesn't mean there's a defect here. You have to add color 3D into that to confirm this is paravalvular dehiscence and leak. This patient went into multiple blog. You can see 1, 2, 3, 4. Unfortunately, he didn't do well after that and died from recurrent bacteremia of his valve. So this kind of interesting case I would like to share with you to the use of 3D color in patient with prostatic valve. Now, cardiac masses, 3D has a lot of advantages. It can give you characterization of the mass location, size, shape, mobility, and most importantly, the spatial relation to the surrounding structure. How many times you're in the echo lab arguing about echo density that you see on the aortic valve? Is this lamellus excrescens or this fibrostoma? And look at these two images. So here, there's two videos. So on one on the left here, I want you to look at the left cusp. I want to see, you can see very clear long filament, okay, across on the closure line of the left coronary cusp. Very classic, right? So this is just giving a rotation. This is the short axis of the aortic valve. This is the left atrial this is the atrial septum that intersects the non-coronary cusp. This is the right coronary cusp with the 3D of the aortic valve. The right coronary cusp always around 6 o'clock. Either you look from the aorta or look from the LV, that will be in the same view. And this is the left coronary cusp. And here you can see very filamentous structure, lamellus excrescens. If you take a look at it again. So if you guys appreciate, there's some drop off here at the non-coronary cusp. This is not perforation. This is because the leaflet is very thin, and we have a limitation with the 3D with the drop off. If you consider about perforation, you need to add color to it. So if you see a color to it, that confirm that. If not, this is just drop off. So keep that in mind. Now, if you look at the clip on the right screen here, again, the same. This is a short axis 3D zoom of the aortic valve. This is the intra-atrial septum intersect your non-coronary cusp. The right cusp always at 6 o'clock at the bottom, and this is the non-coronary cusp. And here you can see there's like a globular echo density mass on the LVOT side of the valve, close to the closure line, but definitely you can have more confidence calling this fibrostoma, convert this with the lamellus excrescens. So 3D can help you differentiate the cardiac mass when compared to the echo. Now for interventional cardiac procedure, 3D, especially 3D zoom and live 3D, they have a lot of advantage and help us tremendously in terms of procedural planning, diagnosis of the defect, the lesion accurately, procedural guidance, and also for follow-up after deployment. For example, here on the left, you have a mitral clip. You can see alveolar stretch here with the clip. You can assess for alignment, help with the procedural deployment of the mitral clip, and also post-operatively you can do accurate planimetry for the mitral valve area, because when a concern with the mitral clip, you don't want to end up with the residual mitral stenosis. For the left atrial occlusion device, as you know, there's a different morphology for the left atrium appendage, and some of them are unfavorable for the closure device, and some of them favorable. So 3D echocardiography using multiple reconstruction help us assess the actual anatomy of the left atrial appendage and accurately assess the left atrial os, which we rely on for sizing. So it's very important to use that. And also for post follow-up, looking for a leak. This is the mitral valve view from the atrium, and you can see at 9 o'clock here, this is a Watchman device, well seated, nice shoulder, and we add color 3D to it, and I don't see any color around the device. There's no very device leak, which is one of the criteria that we look for to stop anticoagulation at the 45 days post-implantation. So it's very valuable because with the 2D, when you scan, sometimes you miss a leak here and there. But with 3D, you have a comprehensive panoramic view of the Watchman device, for example, looking for the paravalvular leak. Sorry about that. This is an important paper from the ACC guidelines on the image acquisition, display, and processing, published in 2012. I highly recommend you guys spend time on that. Dr. Roberto Lang and the rest of the group did a wonderful job about very practical point, how to obtain a nice 3D image, display them in an anatomic accurate way, and how to do processing on that. So let's talk about some practical point here. What's the step that you go through when you obtain 3D imaging? The first, you have to start with the good 2D image. It's a must. Good 2D will give you good 3D. So if you have terrible or poor quality 2D, don't even waste your time. You're not going to get with the image. So make sure you optimize your image, adjust your gain, adjust your depth. By decreasing your depth, you can increase your frame rate, which help your temporal resolution. In general, having a frame rate between 20 and 30 hertz, it will provide a good temporal resolution. So first is you start with your 2D image, optimize them, have your focus depth on the region of interest. Then you choose your mode of acquisition. We have a live 3D, 3D zoom, full volume, and color Doppler. We'll talk about that 3D. Then you render your images, you acquire that. And after you acquire the image, you have the option to display the image by cropping, adjusting it, and you end up with the final image here. So for example, if you see here, this is a patient with bicuspid aortic valve, and look at how nice the 3D image for the same patient. Now, talking about the image acquisition, as I said, in general, there's two types of image acquisition. There's a real-time or live acquisition and full volume, which is ECG gated. So for the real-time, we have the live 3D. It's a narrow sector, like a pizza pie here. It's usually 30 by 60 degree. And we have the 3D zoom. It's a small pyramid, usually 30 to 30 degree. And we have what we call a thick slice, the full volume. If you think about like a pizza slice for the live 3D, this is New York style for the live 3D when you have a thin slice. And for the full volume, it's like a Chicago style pizza, which is very thick. And the 3D zoom is just taking a zoom out of this. So for the full volume 3D zoom, it's usually a large sector. You can see here, it's 90 by 90. A large data set. You cannot do that live. You have to have EKG gated. You can do it through 2 beat up to 6 or 7 beat. And what you do that every single beat, you take one sample of that data set. So you can, and the problem with that, we end up with a stitch artifact, but it's helped you a lot, especially when you do volume assessment. This is, again, this is the live 3D here, like a narrow angle, 30 by 60. And this is the 3D zoom. Now, for example, when you take a live 3D, which is very helpful for procedural guidance, you can change your lateral elevation width going from medial. You can see here the right atrium, tricuspid valve, aortic valve. You can go on the center, and you can go more lateral to get your RVOT. So you can control that without dialing your probe. Just wherever you are, you just hit one button to go from lateral plane from left to right. When we talk about 3D zoom, it has a lot of advantage when you're looking for a certain structure, valve, for example, mitral valve, aortic valve, or left atrial appendage, always use 3D zoom. It has excellent image quality and spatial resolution. The temporal resolution is low. So if you're looking for temporal resolution, you need to do more full volume and acquire over 4 to 6 beats. If you can see here on the left, this is 3D zoom of the mitral valve. You can see each scallop A1, 2, 3. So your appendage here on the left, on the lateral here. And look at the same, and very identical to anatomic specimen here. So that's a big advantage for 3D. And I recommend that each one of you learn how to do mitral valve 3D, and I'm going to show you how to acquire that. Now, when you talk about full volume, as I said, it's a large data set, and you can see with every part of the heart segment that you need to acquire to a different single beat. The limitation with that, the stitch artifact, but you can get a large cardiac volume You can improve your frame rate as high as 40, but you require EKG gating, so it's very important to that. Full volume 3D, that's been a limitation for 3D echo due to the frame rate, especially when you're looking for regurgitant volume. But lately, with the improved technology, we were able to acquire similar data set with one single beat. So I think the field has advanced dramatically in terms of color 3D. And this which help us for assessment for the vena contracta, for the effects of area. For example, as I said, with 2D, we assume using a bead that it's a circular rounded. Look at this patient here, measured with multiple reconstruction, it's completely elliptical. It's not over rounded. And look at the area, effective area is 0.92. So 3D help us understand the regurgitant lesion much better with more accurate assessment. Now, so which 3D mode should you use? So it depends. If you're looking for chamber quantification, LV volume, ejection fraction, and mass, definitely use full volume because you need large data set. If you're looking for a structural defect or congenital defect, like example lesion on the mitral valve, aortic valve stenosis regurgitation, you start with the live 3D color, especially 3D if you're looking for regurgitation. Make sure you increase your color filter to get rid of all the low flow there. You just want to get the high regurgitant flow and 3D zoom. So that's the way to go for if you're looking for valve lesion structure 3D zoom. You still can use full volume, but mainly we use 3D zoom. If you're guiding interventional procedure, you need to use live 3D and 3D zoom. Okay, these are the technique that you would use, and this may be some question that will come to your board exam. They ask you which technique would you use. Now let's kind of do a very practical exercise here about the mitral valve, how you acquire that. I know people use different vendor, but the concept is the same. So always start with your 2D image. Optimize a nice 2D image, mitral valve. It doesn't matter if you want to do it at 0 degree, 60 degree, or 90 or 120. It doesn't matter. As far as you see a nice mitral valve, and you hit the 3D zoom bottom to get your box. So you have your X, Y, the depth, and the lateral width. Okay, you acquire that, and you're gonna have what the 3D offer us, the lateral elevation, So you can get like another perspective that we don't see with 2D. So if you can see here, I'm 125 degree here, because I see the aortic, I'm 0, sorry, here, you can see some 5-chamber valve. When I added level, I went to around 90 degree perspective. So I have like the lateral width, elevation width, and depth. Then you hit the 3D zoom bottom again, and that will acquire the pyramid, the 3D zoom pyramid when you have your X, Z, and Y. Okay, you can see the one here. So what would you do on that? So this is from the left atrium. So, okay, what you need to do, you tilt this whole data set downward. Okay, you hold, so this one here, if we go to 6 o'clock, you tilt it, you tilt it down to 6 o'clock. And what you're gonna do, you need to move your aortic valve a 90 degree clockwise or counterclockwise, doesn't matter, as far as you move your aortic valve to the 12 o'clock view. One thing I would recommend when you do that, hit the freeze bottom, okay? Hit the freeze bottom there, it will make it easy for you to manipulate, to, again, bring this data set downward to 6 o'clock, then you rotate clockwise or counterclockwise to bring the aortic valve at 12 o'clock, and you decrease your gain, and you see the anterior mitral leaflet. This is the posterior mitral leaflet, appendages here, and the aortic valve here. So this is how you acquire. So make sure you do that, go practice. If you're holding the probe when you do your TE, take a look at the sonographer, what they do. Or if you're attending, grab the probe from you, just go on the machine and tell the sonographer, show me how you do 3D. I want to learn, because you have to practice, okay? You have to practice. Now, for the people who does scrubbing for structure procedure, you need to be familiar with the 3D of the atrial septum. You can acquire that at 0 degree and 90 degree. I personally prefer to do it at 90 degree, the bicaval view. So this is this data set of the appendage. This is the left atrium side, atrial side, the bottom. So what you do, you need to tilt. If you're looking from the atrial side, tilt the data set upward. And this is your SVC, usually at 3 o'clock, you need to rotate counterclockwise to bring it to 12 o'clock. You can see here, this is your SVC, There's IVC, there's catheter coming here, and this is the fossa ovalis. In this view, the aortic valve at the right of the screen, 3 o'clock. If you look at the left atrial appendage, you can see there's a lot of smoke here. This patient had probably had some AFib, and the aorta valve will be on the left. So if you're looking at the septum on the right side, the aorta will be on the right. If you look at the atrial septum from the left, the aortic valve will be at the left side at 9 o'clock. So that's something you make sure you understand. Just again, just go again, you tilt the whole data set up, looking from the right atrial perspective, the aortic valve here on the right side, because I'm looking on the right side of the septum, 3 o'clock. Okay, this is the catheter, SVC here, IVC here, coronary sinus going this way. Now, if I'm going to look at from the left atrial side, I move the aortic valve into the left at the 9 o'clock. Okay. Now, the same paper I showed you, the 2012 ACC guidelines, it shows you how to manipulate these images and put them on anatomic standard orientation. Here, the mitral valve always will look like this way. Don't get confused. There's a lot of grain. Just tilt it down 90 degrees, then rotate, bring this aortic valve to 12 o'clock, and that's it. The pulmonary valve, we don't do it as much. A very thin leaflet. I don't think you need to waste your time on that. Maybe in the future. Tricuspid valve, actually, you have better success if you do it with the transthoracic echo because it's anterior structure, so you can have that. And generally, when we acquire that, we would like to have the ventricular septum at 6 o'clock. Either you're looking from the RA or the RV, you want the septum from the 6 o'clock. This is the same 3D presentation from the ACC paper, highly recommended. And just the point I want to make sure you understand, the landmark is very important to understand. So if I'm looking at the mitral valve, my landmark is the aortic valve. Either I'm looking from the LA side or LV side, the aortic valve always be at 12 o'clock. For example, with tricuspid valve, either if I'm looking from the right atrium size or right ventricular size, the interventricular septum always at the bottom at 6 o'clock. Looking at the aortic valve, I'm looking from the aorta or the LVOT, the right coronary cusp always will be at 6 o'clock. So that's kind of the concept you need to understand, and when you present that with your images. And it needs a lot of practice. Now, how you optimize your 3D images. This is a nice poster that you may need to hang in your lab from ASC. It shows you like what views you acquire these images, either from transthoracic and transesophageal, how to optimize your images and the right anatomic display for these images. So first, the most important thing, 2D, 2D, 2D. You have to have a nice 2D image. So optimize your image, 2D, take your time, adjust your gain, adjust your depth, increase your frequency, and do that, okay? Because quality of 3D image always start with good 2D image, then you adjust your gain, okay? You usually, when the 2Ds overgain a little bit, then you can zoom on the region of interest. Don't get greedy. Don't get like the aortic valve and the appendage and the tricuspid valve. Just stick on your mitral valve and take a small bite of the aortic valve. If you're looking for a left atrial appendage, sorry, if you're looking for the left for the mitral valve, if you're looking for the aortic valve, just take a small bite from the atrial septum. Then you adjust your focus depth. Make sure you have it at the region of interest, and then you choose the small sector, as I said. Now, after you acquire your image, the whole you have the raw data set. You start the post-processing and use your multi-binary reconstruction. Depends on the vendor. Right now, most of them have automated way, but we go over a few things, the cropping, and this is basically how you kind of crop through the data set. You go like interior to posterior, medial to lateral, or superior to inferior. You adjust your gain. They'll talk about the compression, the brightness, smoothness, and color map vision. Now, the gain, what the gain does, the option is to remove the noise from the structure. You start when you get your 2D image, you overgain a little bit, then you undergain till you have a dropout. So normally we say undergain there's no more grain. Okay, that's kind of rule of thumb. Okay, so in this one, the one here in the left bottom, the most one, usually you want to have your gain like around 20, 30 at the most. You don't want to too much lower or high. The compression, what the compression does, it adds some soft texture on your structures of interest. The compression, it make the structure more homogeneous, okay? So if you go down on the compression, you make it more prominent. If you go high on the compression, you make it more smooth. So in general, we recommend the lower compression between 2 and 4. It's from scale 0 to 10. So for me, this will be more appropriate than this one here on the right bottom. In general, you want a lower compression when you have like a protrude structure into a cavity. For example, pectinate muscle or mitral scallop like here. So you want a lower compression. Brightness, basically you want to have nice illumination of your structure. So for example, on the top left here, it's too dark. You have like under illumination. On the right bottom here, you have over illumination. In general, we recommend 40 to 50 in scale of 0 to 1. So there is no clear setup. It's kind of with practice, you kind of get what you want and what you like as far as you appreciate the anatomy you're looking for. Smoothness is very similar to compression. I see the other way around. It adds some subtle roughness to the structure here for the atrial septum, for example. In general, we recommend to use a medium value between 6 and 8. The last option you need is the color map vision. And that's a gray scale, scale shade. It just basically what does it help you with the perception, the depth of perception. The most common one use the bronze and the blue vision. Everyone is different. Personally, I like this one for me, the F we call it. So everyone is different as far as it help you appreciate. For example, here, this is the looking from the atrial septum from the right atrial view. You can see the SVC, crista terminalis, right atrium, you can, and this is PFO, you can see a catheter here. So I appreciate the catheter in this view and this view more than this view, for example. So this is kind of how, what your perception. It's the same thing with the 2D when you change to your scale to the warm scale, the bright scale. Now, with the advantage of 3D echo, it helps us evaluate the cardiac chamber volume and mass with good reproducibility and accuracy compared to 2D echo. It helps us assess the regional wall motion abnormality and idiosyncrony. It gives us a realistic view for a heart valve. Like I show you this example with that flail A2 segment of the mitral valve and the mitral cleft that it's very hard or no way to diagnose that with 2D echo. It also helps us a volumetric evaluation of regurgitant lesion and shunt by adding 3D color. What's the disadvantage of 3D echo? It's time consuming. It takes a lot of time. I spent a lot of hours doing that. Required training in 3D analysis. Different vendor, they have different techniques and processing. Knowledge, you need to learn those. The accuracy vary with expertise and vendor. Sometimes like different expertise, when they look at the data set, they crop it, they give you a different result. So we still have some room to work here. The timbre resolution is the main limitation, especially for stress echo at this point of time. As I said, you need a higher frame rate to pick up that wall motion abnormality post-exercise. So that's, I'm hoping in the future, we're gonna see more advance on the timbre resolution. And the most important thing, it relies on good 2D image. So make sure you have a good 2D image when you're thinking to do 3D echocardiography. I'm going to end up here. I think we're out of time. 2 minutes left. Everything in nature is a 3D, and the heart is a 3D structure. So the best way to image the heart using a 3D modality. Thank you so much for listening, and my apology about the technical difficulty we had at the beginning.
Thank you very much, Dr. Smair, for a great presentation. I have one question in the chat box. When would you use high volume rate versus multi-beat for full volumes? Also,
excellent. Yeah, excellent question. So in general, we use the high volume rate. This is when you have a regular heart rate. And for example, patient with atrial fibrillation, that's your mode for acquisition. And what's basically what do it, try to kind of get as much information from 1 and 2 beat than just the variability of the heart rate. In general, when you look for 3D volume, you want to acquire large data set. So getting an image between 2 to 6 beat, you get an accurate information. The limitation with that, the stitch artifact that you see in those cases, and that's very prominent with AFib. So HVR, this is a different technique that some vendor created just to kind of help us avoid that stitch artifact and get accurate information using the full volume. Yeah, good question. Mainly in AFib and a regular heart rate, patient with frequent BVC or PACs. Excellent, yeah.
and just a follow-up question, I think you already answered, but the follow-up question was any tips for acquiring decent volumes in AFib?
Sorry, say that again.
Just a follow-up question to that. Any tips for acquiring decent volumes in AFib
For 3D or in general?
for 3D?
Yeah, for 3D right now, as I said, the technology, it's there like it's not, it has some limitations. So if you remember the slide I showed you, it's still superior to the 2D images, but there's two way of assessment of the 3D volume. There's like a tracing method that has a lot of limitation with if you don't have a good 2D, you can trace you can include the trabeculation, which give you inaccurate information underestimation, and the other one by actual volumetric. This one is very similar to the 3D imaging, but I'm not familiar, to be honest with you, that in AFib how that will complicate this. You know, like with different cardiac cycle, you get different volume. In general, the rule of thumb when you have AFib, you need to average your reading. So what I would suggest, get more than one reading and do it when the heart rate close to the 60s, so you have less variation. You don't want to do it when patient's tachycardic, to give you more accurate information.
Thank you very much. I don't see any other questions in the chat box.
And one more thing, for that heart model I showed you, it's a single beat. It's a single beat. So it will assess the left ventricular end systolic volume, and then there's one beat. So in AFib, the only issues with that, if you acquire that beat during a long cycle or short cycle, right? If you acquire that during a short cycle, will give you less volume compared when you do it a long cycle. So to keep that in mind, which cycle you choose. So that's keep that in mind. Yeah, that's a good question. Very good question.
Thank you very much, Ayman. That was an excellent talk. Thank you very much for your contribution to the fellow education. Much appreciated.
Thank you so much. My pleasure. And thank you for the invitation. Thanks everyone for listening. Have a good one. And again, Ramadan Kareem and happy Ramadan to everyone with us. Thank you.
Happy Ramadan to you too.
Thank you.
But to move on to our next speaker, Dr. Karthikeyan Ananthasubramaniam. He's a professor, he's a clinical professor of medicine at the Wayne State University School of Medicine. He's director of nuclear cardiology and PET program and the program director for the Advanced Cardiac Imaging Fellowship at Henry Ford Hospital. Dr. Anand completed his medical school in 1991 at the Madras Medical College in India, graduating as the best outgoing student. He completed his internal medicine chief residency and cardiology and echo fellowships at Henry Ford and was awarded the Francis Fernandez Fellowship Excellence Award in 1999. He subsequently completed advanced imaging training in nuclear cardiology, cardiac PET at the University of Ottawa in Canada, cardiac CT and MR at Beaumont Hospital. He is board certified in cardiology, adult congenital, nuclear cardiology, echo, and cardiac CT. And he's a fellow of ACC, ASC, nuclear cardiology, cardiac CT, cardiac MRI, and also a member of the AHA. He's been elected to lead the Michigan chapter of the ACC, and again, he's one of the speakers who kind of came to our assistance when we were looking for speakers to for particular topics and so on. So really appreciate your contribution for this, Karthik. Over to you.
Thank you so much, Mahi, and thanks to Jay for his communication and help and everything, and really wonderful sessions that you put together for the benefit of fellows around the country. So my talk is going to be contrast echo. Obviously, after the wonderful talk and the images that you've seen, I'll try to bring you down to earth with some more mundane daily use of contrast echo. This is also now known and preferably known as the ultrasound enhancing agents, as the American Society of Echo has kind of taken the chance to get rid of the word of contrast so that patients don't feel intimidated by that word. But for the sake of time, I will continue to use that word through the presentations. Here are my disclosures and some acknowledgements. And so for the board exam, what I've tried to do in this presentation is try to put together the content so that it is practically applicable for you in daily practice and focused on the board exams. This is the NBE board exam outline, showing that contrast and perfusion, even though perfusion is not formally widely used, I think the concepts are very sound, and so we will definitely go into it. So the recommended read I would suggest is two papers, apart from the contrast zone in the American Society of Echo website, which kind of gives you a lot of information, but these are the most updated guidelines, both from the sonographer standpoint and from the physician standpoint, that I would recommend as a read for you. So the objectives, hopefully I'm able to cover all of this. We'll start off with some kickoff questions. And what I would suggest you to do is to look at the questions, note down your own answers, and then we can revisit the questions at the end and you can kind of see where you stand. We're going to talk about rationale of echo contrast agents, bubble physics, the contrast agents in left ventricular opacification and its impact in daily practice. We're going to talk about myocardial contrast perfusion basics, touch on saline contrast echo and some miscellaneous uses, review the safety data on contrast, a few image optimization tips, and then we'll revisit our questions back. And if time permits, we'll do cases. So the first question is, one of the key characteristics enabling current use of microbubbles in clinical contrast echo for left ventricular opacification and perfusion is nonlinear oscillation property, a bubble size greater than 10 micrometer, easy diffusibility, or optimal nitrogen oxygen content. So note down your answers for yourself, and then we'll move on to the next question. So in this still frame image, which is shown, the most likely reason for incomplete opacification noted in the image is a high mechanical index, wrong filter setting, too little contrast, or IV infiltration. Third question, the majority of intramyocardial blood volume resides in epicardial arteries, arterioles, venules, or capillaries. And the fourth question, which is a cine clip, the depicted cine clip shows which of the following features. Is there a layered thrombus? Is this Takotsubo cardiomyopathy? Is there normal microvascular integrity? Is there an infarct with microvascular no reflow, or is there an infarct with successful reperfusion? Okay, and then the final, for those who like a challenge, is we have a spot diagnosis for a 30-year-old with a history of complex cyanotic congenital heart disease treated with palliative surgery and comes into clinic for routine follow-up. He undergoes an echocardiogram and a saline contrast study. So the question really would be, what is the purpose of the saline contrast study? So the goal would be to come up with a possible diagnosis so that we know the purpose of the saline contrast study. So we're going to revisit all these questions and we can discuss it, and happy to use the chat function later on. So we all are very familiar with the limitations of current echocardiography, even with harmonic imaging. The visualization of the endocardium, which is essential for assessment of LV function, is a challenge. It is very operator dependent and sonographer dependent. The endocardial dropout, even with the best of images, is in about 5 to 15% of the studies. And many of the comorbidities that we deal with daily complicate our interpretations. And then when we look at suboptimal images, what is the impact on the patient? Is that obviously there is misdiagnosis, there is low diagnostic confidence, there is need for additional testing, and a significant inter-observer variability, which has always been the Achilles heel for echocardiography. And here in the cine clip, you could clearly see that there appears to be left ventricular dysfunction, but assessment of wall motion, particularly of the apex, seems to be a little bit challenging. So contrast echo obviously comes with a lot of promise. It has been used for quite a few decades now. It gives us increased sensitivity, heightened diagnostic confidence. It improves the accuracy and reproducibility, and it enhances clinical utility, as we will go through all of these in our talks. So here on the right side, you can now see a contrast-filled image showing an extremely large intracavitary mass, which is not very much filling with contrast, likely, given the wall motion abnormality, very likely a thrombus. So a few historical things so that we set the stage for why we use the kind of microbubbles that we use. I think the credit for contrast first goes to Gramiak and Shah when they were doing M-mode echocardiography during aortic imaging, where they noticed a puff of echoes appear when contrast was actually being used for during cardiac catheterization. But the things which was quickly realized with the air bubbles was that these air bubbles, which we form with agitation when we use two syringes to agitate it, they are pretty extremely short-lived. They're very suitable for right heart opacification, as we do with saline contrast. You can use them for tricuspid regurgitation and intracardiac shunts, but the problem is they're unable to traverse the pulmonary circulation so that they can't get to the left side and cannot last long enough for you to do durable enhancement of the left ventricle. So let's get into a little bit of the bubble physics. So the normal RBC is about 6 to 8 micrometer. So for something to survive in the circulation to get into the left side, it has to go through the pulmonary transit. And typically bubbles which are greater than 8 to 10 micrometer are not going to be able to make it through the pulmonary transit. So fundamentally, for us to be able to visualize bubbles, they need to be stable. They need to be intravenously injected. They have to cross the pulmonary filter. They should be resistant to all the intravascular changes in pressure. And they should be stable when they face the ultrasound beam. And obviously, they should be able to improve the Doppler signal to noise ratio. So most of the microbubbles that we're going to be talking about fall into the category size-wise of being less than 8 micrometer. And so when you look at moving from air-based contrast to second generation contrast agents, you can see that the first thing is that their shells are made up of either lipid or the albumin. So the albumin was is seen in optosun, and the lipid shells are seen in definitely Cernoview and Cernozoid. And then the gas score, which is again the stability of the gas. So air is freely diffusible, and that's the problem. So as air diffuses out of the microbubble, your bubble is going to shrink. It doesn't survive the pulmonary circulation. You lose opacification. So you need to have a stable shell, and you need to have a stable gas or a higher molecular weight gas, which can stay and be stable so that you can actually image them with your ultrasound. So if you look at these bubble sizes, even though their range is there, most of these bubbles are much less than 8 micrometer in diameter. So now, once we know that the gas as well as the shell makes a difference in imaging this, how do these bubbles interact with the ultrasound machine? And then comes the concept of the mechanical index of the acoustic power of the ultrasound machine. So what we know is that when the ultrasound sends out a beam, tissue and blood respond in a linear fashion. Whereas what has been noted with gas-filled and stable shell microbubbles is that as you increase the power of the ultrasound or the peak negative pressure or the mechanical index, these bubbles start with a slight nonlinear resonance, which progressively increases, and at an extremely high mechanical indexes, they have significant nonlinear resonance, but they also disrupt at the same time. So from fundamental to harmonic enhancement and bubble disruption, by varying the mechanical index, you can induce different behavior of these bubbles, which is being used both for pacification as well as for myocardial perfusion imaging. And so in summary, when ultrasound stimulates these microbubbles undergo compression rarefaction and change in size and shape. This is fundamentally different from tissue, which actually gives you a linear resonance. So the modern ultrasound machines use a filter to filter out your tissue signal and enhance these nonlinear second harmonics produced by these bubbles so that you can actually see the endocardium or the blood pool to endocardial interface. So in principles of harmonic imaging, if we look at the fundamental frequency and twice the frequency, you can see that plain old myocardium basically does not have any significant second harmonics. But when you add the contrast agent to it, you can actually see that the contrast agents produce this nonlinear resonance, which is fundamentally the basis. So this fundamental property of nonlinear oscillation and backscatter is what is critical for microbubble imaging and opacification and perfusion. So if we break down bubble behavior, acoustic behavior, and clinical application, you can see that by varying the mechanical index, you can deliver different clinical applications. So at mechanical indexes, which are extremely low, you can get fundamental left ventricular opacification and spectral Doppler. And as you will see in many of the cases that I show you, most of the times when you do mechanical index. And remember that these are all contrast settings which are already set in modern machines. You don't need to do much at all. So you just need to hit the contrast setting where the MI is all set. But at very high mechanical indexes, and we use this currently only for flash imaging, which is one of the cases that I showed you, where you maintain the mechanical index low, but then suddenly increase your mechanical index so that you can destroy the bubbles to see the replenishments of bubble in the myocardium. Otherwise, really, highly destructive flash imaging is not used routinely for myocardial perfusion. So how do we give contrast? We typically can give it either as a single intravenous bolus, and this is what I think most of us in our labs do. This is very simple. And depending on the manufacturer, may need very quick preparation by either even just rotating in your hand like an Optison, or you may need a vial mix as in Definity. But the problem is when you give these boluses, they are not standardized, so you must wait for attenuation to resolve. And it's not great when you do myocardial perfusion imaging. So it's good for LV opacification, stress echocardiography, and other things. But when you're trying to image the myocardial perfusion, not opacification,
You want this or you want the joint?
and you may land up with continuous infusion protocols at that time. So to summarize, you can see that air is highly soluble. It doesn't persist too long, and it doesn't have great stability, and it rapidly diffuses after disruption. Whereas the heavy gases, which form our second generation contrast agents, have got higher molecular weight, low stability, solubility, high persistence, and stability. So what are the main indications? Now that we've kind of learned the basics of the bubble physics, you can see that contrast enhanced echo, and all of you know this and use this in daily practice, is fundamentally used for left ventricular volumes and ejection fraction assessment, but it is also used to define various LV morphologies and identify pathology within the LV cavity or in the LV myocardium. And then it can be used with modifications of what I told you with mechanical index adjustment. And I'll show you an example of being able to get an initial thought process of what a cardiac mass may resemble based upon the vascularity. Improved right ventricular visualization, improvement of Doppler signals, use in stress echo, and perfusion, which is still kind of not widely used and it's off-label. So for the purposes of approval and for your understanding, contrast agents are currently only approved for left ventricular opacification. So obviously, the most common diagnostic use is global ventricular function assessment, LV morphology, and rest and stress. And you can see there is tremendous difference in change in inter and intra-observer reproducibility once you give contrast. So here is an example of a non-contrast image where it is clearly challenging to know if this left ventricle is dilated. It definitely looks dysfunctional, but a right ventricle is not greatly seen. But once you give contrast, you can see that the left ventricle is remodeled and spherical. It's dilated. There is no clear intracavitary mass, but definitely there is slow flow with stasis and swirling. And you can also see that the right ventricle gets better defined, even though we will need to do RV focused views to bring in the right ventricle much better. So impact on this case is left ventricular opacification with contrast to delineate left ventricular size, function, and wall motion. Now, when we then take it the next step to look at morphology, here is a case again where the mid to distal ventricle is challenging to see. If you only looked at the epicardium, you would even wonder whether there is a little bit of dyskinesia of that periapical segment. But lo and behold, when you actually give contrast, you can clearly see that there is no dyskinesis, rather that there is asymmetric thickening of the distal portions of the septum and periapical walls consistent with apical hypertrophic cardiomyopathy. Now, the same thing can be applied in exercise echo, and I think this again boils down to having a protocol in the lab, educating the sonographers and giving the sonographers the right to actually use contrast under a standardized supervision of the physician. The sonographers shouldn't have to search for the physician to initiate contrast. So I'm sure in many labs, like in our labs, we have a standing protocol giving permission for the sonographer to use contrast. So here's parasternal images in the exercise pre-baseline echoes is good quality, but you can see the apical images are challenging. So particularly for exercise echo, it's very important to recognize this because you usually don't have an IV. And so the sonographer needs to plan for this in advance. And that is because about 30% of even harmonic imaging stress echoes still are suboptimal. And the multi-center agreement on wall motion is as low as 43% even in expert centers if you do not use contrast in stress echo studies. So much so that some centers routinely use contrast for stress echo. So this same patient, now you can see excellent definition of the left ventricle, not only the left ventricle, excellent definition of the right ventricle, both at rest and stress, suggesting normal wall motion. So now let us move to impact of contrast. So what does this mean? So if you look at this, this is a very, probably one of the most impactful studies that I'm aware of in contrast echo. There's not a lot of large studies looking at patient impact. And you can see in this study, you can see particularly where you look at uninterpretable echoes, you can see that that goes from 11% without contrast to 0.3% with contrast. So that's probably a huge difference when you look at interpretability of studies. Now, when we now look at fundamental imaging, harmonic, and then add contrast, you can see compared to MRI, which is traditionally considered the gold standard, the correlation when you use both harmonics and contrast is the closest compared to just using fundamental or just harmonics alone. So correlations to the reference standards much better when you add contrast. Now, taking that one more step, what about three-dimensional echo with contrast? And in this very nice study, we're comparing it to gold standard MRI of 50 patients with prior MI, where you use normal 2D, contrast 2D, contrast 3D, and non-contrast 3D. And if you focus on the bars, with red being MRI, you can see that contrast 3D echo comes closest with regards to estimation of end diastolic and end systolic volumes and EF. Even with contrast 3D echo, there is underestimation, but the degree of underestimation is at its lowest. So if you have the capability of three-dimensional transthoracic echo, which many of the newer machines and softwares have, adding contrast to that really makes it robust. And this is particularly very influential for cardio-oncology programs where precise estimation of ejection fractions is needed. So what about effect of contrast on diagnosis of thrombus? In this particular study, you can see the indecision of whether something is a thrombus or not before contrast, and how after contrast there is substantial confidence in calling thrombus or not. So here is an example of a case, a 66-year-old male with enteroapical infarct presenting with a TIA to a lab. Challenging, you already know that there is a wall motion abnormality there, but you can't see well. Whereas when you give contrast, you can clearly see the layered and protuberant thrombus in the left ventricular apex at that particular point. Here is another interesting case of a patient where you can see that there is a hazy mass seen in the left ventricular apex in this particular area. Unclear whether this is thrombus or not, but the moment you actually give contrast, you can actually see that that area completely clears up. And these may be easier to delineate for experienced readers, but for novice readers or people who are not comfortable with calling this, it would be challenging and they may raise concerns. This is nothing but a near-field clutter artifact, which is typically created by high amplitude reflections from the piezoelectric crystals, and it appears as a diffuse haze, which really doesn't follow anatomic boundaries, is not usually associated with a wall motion abnormality, as in this particular case. So in summary, effectiveness of contrast you can look at, we know that it improves adequate LV enhancement, it improves evaluation of multiple segments, it salvages wall motion evaluations where we are not sure, and this is one of the big ones in this particular study and in others, where depending on the reader, close to 60 to 90% of the times, wall motion indecisions are helped by contrast. And then non-diagnostic examination salvage, and segments with change in evaluability, where you thought it was hypokinetic but not, and vice versa. So now that we know that contrast is very helpful in making certain impact on the echocardiogram, how does it actually ultimately affect patient management? And this is a very nice study done in the late between 2005 and 10 of around 4,000 patients from the Houston group, where they actually took patients with suboptimal echoes, called the referring doctor and said, hey, this is the report before contrast, what would you do? And then they gave them the information after contrast to see the impact and change in management. And this is important, because if you look at all of the patients that you and me take care of, look at the inpatient wards, MICU, SICU, and outpatient. The most challenging patients, where it's uninterpretable studies, in this particular study, and I think all of us would agree, are these patients in the surgical ICU with all their dressings and stuff. But the moment you give contrast, you can see you practically wiped out the uninterpretability, even in the most toughest of these groups. And then when you looked at total impact on the patient, looking at additional procedures avoided, medication changes made, and then the combination of both medication and procedural changes, you can again see that here's the sickest of the population, and you can see that is where contrast had its maximum impact, where both medication and procedural changes were very impactful in that particular. So in summary, I would say take-home points from the left ventricular opacification side is superior endocardial border and left ventricular morphology definition. The volume underestimation from the heart standpoint is markedly reduced. There is significant inter and intra-observer variability of LV volumes compared to reference standards. That is improved. Segment visualization is improved. 3D contrast echo is better than 2D. And then obviously there is a positive impact on patient management. So now let's shift gears to myocardial perfusion. And so let's review a few physiological concepts so that we can then put the perfusion into perspective. So the first thing to note is that when we look at the circulation distribution in the myocardium, so you have arteries, you have arterioles, you have capillaries, venules, and veins. The microcirculation, particularly the capillaries, hold close to 90% of the myocardial blood volume. So when you are actually imaging perfusion, and I say this as a common theme, but particularly for contrast echo, whenever you look at perfusion, you're not looking at epicardial coronary arteries alone, right? So perfusion is at the microvascular and macrovascular level. So for example, nuclear, for MRI, PET, anything that you take, you are actually evaluating perfusion at the bed, which is in 90% of the blood volume being in the capillaries. That's what we're looking at. With that concept in mind, if we look at replenishment imaging, or how do we image the myocardial perfusion, typically the ultrasound beam length is felt to be about 5 millimeters, and the transit of red blood cells in the capillaries is very slow, 1 millimeter per second. So if you had a scenario where you had x-axis as time and y-axis as blood flow velocity, and if you actually delivered a high flash signal or a high mechanical index signal to destroy all the bubbles in the capillaries, and you then observe those bubbles filling up over a period of 5 seconds, because of it is 1 millimeter per second and you have a 5 millimeter width, and using the blood volume and the blood flow velocity, you can actually calculate myocardial blood flow. And this is kind of the fundamental principle of how perfusion has been looked at. So there are two main approaches. One is called destructive, where you give that high mechanical index signal with pulse inversion and harmonic power Doppler. And the other one is called power modulation. So we won't be able to get into the details of this, but the bottom line is we're going to be focusing on low mechanical index techniques. So here is a normal case where you have normal myocardial wall motion, and we are going to move beyond LV opacification, and I want you to focus on the myocardium here. This is going to play again, and you can see how the myocardium is white and then suddenly becomes black. So this black is that high mechanical index pulse which is given to destroy all those bubbles and observe the bubbles refill. And normally in resting circulation, because of the 5 millimeter length of the ultrasound and the 1 millimeter per second transition, the normal myocardium should fill up in 5 seconds. So if you're imaging a patient with a myocardial infarction at the bedside at rest, and you do low mechanical index imaging, keep your mechanical index low, and then deliver your flash, you will see a delay in the appearance of microbubbles, and you know that there is a problem at the capillary level. And then when you dial that up to exercise echocardiography, where there is hyperemia, so the myocardial blood flow filling up should happen even faster, maybe in about 2 or 3 seconds. A delay in that fill up would suggest that there is exercise-induced ischemia. So using very low mechanical index imaging interrupted with a high mechanical index flash and observing the replenishment is a way to actually delineate microvascular integrity. Now, this has been looked at in numerous studies. A lot of centers have done some pioneering work in this. This is just a summary for coronary artery disease and viability assessment. And here again is a fundamental concept which I'll take a minute to kind of divulge into for all the fellows. Is you can see that with myocardial contrast echocardiography, we are looking at microvascular perfusion and integrity. And so when you look at perfusion-based techniques, be it again nuclear PET or perfusion contrast echo, you will fundamentally see that the sensitivity is pretty high. However, the specificity is very variable. And this is the same kind of the tune you will hear with nuclear imaging and PET. High sensitivity, slightly lower specificity, whereas with echocardiography or stress echo or dobutamine echo, you will always see a slightly lower sensitivity, but a slightly higher specificity. That's because you're fundamentally evaluating perfusion with a myocardial contrast echo or nuclear, whereas you're looking at wall motion with echo. So understanding the difference is important because very often it becomes a scenario where we take a patient with a positive perfusion scan or a positive perfusion myocardial contrast echo to cath, and we may or may not find obstructive disease. That doesn't mean the technology is wrong. It means that you are picking up microvascular integrity problems earlier than what you would expect with obstructive disease. And in general, that's the reason why if you look at the ischemic cascade, perfusion-based changes like CMR, myocardial perfusion imaging or contrast echo are able to pick up abnormalities much before wall motion-based techniques. If we then look at prognostic value, that would now you would start putting things together. We know that wall motion abnormality is associated with adverse prognosis, meaning the worse the wall motion abnormality, worse is the prognosis. But on top of that, if you add abnormal microvascular integrity, you can see that the combination of abnormal microvascular integrity or myocardial perfusion plus wall motion abnormality has the worst prognosis. And you can see that the interesting thing is right in the middle, right? So you can see that if you have abnormal regional function like ischemia, but your microvascular perfusion is normal, you actually have a better prognosis than those patients here. So in general, this concept has held true across imaging modalities. The microvascular integrity seems to trump epicardial wall motion abnormalities in general. And that is why perfusion-based techniques have that kind of strength and advantage. Now, taking it to the next step, you can use contrast perfusion to look at cardiac masses. So here is a pretty large mass. And most people would say, this looks like a myxoma or other things, and that's very fair. And most people would consider doing an MRI, which is kind of the gold standard for tissue characterization. But you can do something in the interim too, is where when you give contrast, you can do exactly what we spoke about just now. You do very low mechanical index imaging, deliver the flash, and once the flash happens right there, you can see that that mass slowly fills up again, which suggests that there is some degree of vascularity in this mass, which means you have excluded likely that this is a thrombus because thrombus is avascular. And so this is a circumscribed mass with some vascularity, which makes it likely that this is a myxoma. Cancer would also have angiosarcomas or lymphosarcomas will also have this kind of extensive vascularity, but usually they will not have this degree of circumscribed and lack of involvement of surrounding structures. And most of the time, sarcomas infiltrate the surrounding structures. So the third part of our talk is going to be briefly focused on saline contrast, because this is also a contrast. So I think the board exams could definitely test you in some of these concepts. And I would definitely refer you to a couple of references, particularly a recent one from Jay's, which has a very nice overview of saline contrast. So we use this for right heart opacification, shunt things. And I'm sure many of you have done this, and I do this very often, is if I do not get good opacification, I routinely contaminate my saline with blood. I just draw a little bit of blood. And the reasoning goes back to our physiology, is that blood actually acts as a surfactant, and it actually stabilizes the air a little bit more so that your opacification gets better. So we all know that these are invaluable and simple studies to do for detecting shunting. But in general, all studies should be performed with adequate patient instruction and provocative maneuvers. And the goal of the provocative maneuvers is to, at the release of the Valsalva, which is phase 2, is to transiently cause that septum to move to create that right to left shunt gradient. Timing alone of the appearance of bubbles is inadequate. All of us remember being taught, less than 5 cycles is a PFO, greater than 5 cycles is a PAVM or a AV malformation. I would definitely not hang my hat on it. I've seen so many cases where if you follow the rule, you may be wrong. So most important is a good study followed by a good septal movement and noting where the bubbles come from and whether the bubbles continue to increase in intensity. If we have the doubt, then we may need to do additional imaging. There are numerous causes of false negatives with a bubble study and numerous causes of false positives. I think false positives are the more challenging ones because you give a wrong diagnosis to somebody, obviously, and eustachian valve can sometimes create the scenario of what looks like a septum, but it's actually a very large eustachian valve. So just be aware of all of that. So let's look at 2 studies. So here is a saline contrast study. I'm going to obviously play this again. I would like you to observe the septum. You're going to see that the septum actually moves in this case, and then there is a significant bubbles which come out. On the right side is a scenario where you have the bubbles come in, but the bubbles start appearing late and start increasing. So I'm going to allow that to play once more, and the bubbles come away from the septum in general. And these may be sometimes challenging, but this turned out to be a very large pulmonary AV malformation on CT. So a couple of miscellaneous cases that I wanted to share with you is LV morphology definition with contrast. This is a patient, is an 80-year-old patient with deep T-wave inversions, chest pain, and positive troponin. She underwent a stat echo in the ER followed by CAT, which showed non-obstructive CAD. Now, observe here, this was a very challenging echo, but the sonographer did a great job in giving contrast, which then brought out this additional wall motion abnormality and like a hinge point at the mid and distal portion. Also observe that even though here, this is not primed for myocardial perfusion, you can see that there is actually bubbles in the myocardium right up to the distal portion, and then there is absent bubbles in the myocardium in the area of wall motion abnormality. And I think this information is available to you in most contrast studies, so you might as well cheat and look at it and say, is there bubbles in the myocardium, which gives you an idea of myocardial perfusion. So anyway, if you look at the cardiac cath, which is pretty dramatic, this patient had a huge aneurysm in that particular location. So this, the ultimate diagnosis in this case was actually mid-ventricular hypertrophic cardiomyopathy with an apical aneurysm. She also had coexistent systolic anterior motion and ultimately received an ICD. The contrast imaging is very helpful in non-compaction. The only caveat in non-compaction is you don't want to turn down your mechanical index too much. You see right here, the mechanical index is set as 0.4. Keeping the mechanical index about 0.2 and less than 0.5 helps to bring out the contrast into the trabeculations and sinusoidals, which are seen very well, rather than very low MI imaging. Now let's move to the safety of contrast. So we all are aware that there was significant issues with contrast safety being brought up back in 2007, and FDA mandated a boxed warning after a series of cases came up where there was temporal relationship to the patient's event, including death and the administration of contrast. So there were significant limitations put by the FDA for contrast use and a mandated period of monitoring. You know, sometimes necessity is the mother of invention. We need this kind of crisis to come out of it and do very well. And starting in 2007, a series of very well done large registries and studies were published. And I'll show you a couple of them to show that contrast was associated with actually no increased mortality. And in some of the ICU patients, actually associated with lower mortality, to say that contrast use helped in decision making to be able to actually make a difference for that patient. So very large studies, close to 19,000, and here close to 4 million studies showing no difference. So the long story short is this led to the boxed warning being removed. So there's really no more mandated monitoring, only precautionary notes given. So it's important to know that contrast is safe to use. And the meta-analysis using all studies clearly showed that there was no significant problems with the use of contrast. What about contrast use in intracardiac shunts? This has always been of concern. And so even this has been addressed fairly well. And I'm just presenting you one representative study showing that actually there was no difference in use of contrast in intracardiac shunts. And currently, it is not considered a contraindication if you have a PFO. If you have a clinical indication where you believe that contrast should be used, a PFO or any small septal defect should not prevent you from using it. Pulmonary artery pressures similarly have been extensively studied, and we now have good data to suggest that there is really no increased mortality or morbidity for patients in all ranges of pulmonary pressures with use of contrast. Finally, we will focus briefly on reactions to contrast. So, and these are called hypersensitivity reactions. And this potentially could be testable also, because one of the important things to know about contrast-induced reactions is they are considered anaphylactoid reactions, not anaphylactic, or it's not the typical type IgE type 1 mediated reactions. And they're typically called CARPA, which is complement activated reaction pseudoallergy. So what does that mean? No prior exposure is needed for this kind of reaction. And the interesting thing is, and this is where I think people get into issues, because the moment patient has back pain or some other issues, there goes into their chart saying that they're allergic to contrast. As a matter of fact, giving contrast in those patients subsequently for good clinical indication has been noted to have milder reactions, and many times there's no repeat exposure symptoms again. Spontaneous resolution happens, but these are much more common than your typical rare IgE mediated type 1 reactions. And all of you have seen some variations of this, particularly back pain, which can be sometimes fairly disabling, and they may need to get some pain medications to get rid of it. So just keep that in mind. It's called CARPA, and the most important thing from practice standpoint is that it doesn't mean that the patient cannot get it or cannot get a different contrast agent for that matter. So a few optimization tips, which may be testable also in the exams. The key thing is most of the current machines already have a contrast setting. But for your understanding purposes, it's important to know that when you normally do non-contrast imaging, your mechanical index is around 1 to 1.3. But when you go into your contrast setting, automatically you will see that your mechanical index is shifted into the less than 0.5 range. And so typically most of these, the very low mechanical index images will be in this particular range of 0.1 to 0.2. If you are facing very large patients, you may need to increase the mechanical index to about 0.5. It's not 0.05, 0.5. Another area where you can be tested is what is the ideal setting for contrast. And typically when you're doing LV opacification, you want to set your transmit focus at the annulus. In some cases, when you're specifically imaging the apex, you can definitely move to the apical level. Here are typically the ideal frequency ranges and frames that you need to be using. Now, what happens if you have too much contrast in the LV cavity? that can lead to what we call contrast-induced attenuation. And so in those cases, what you can do is you can do a brief flash, which is that high mechanical index, to destroy the excess bubbles. However, what do we do if we have swirling, where there's not enough? That could be due to not enough contrast, or your mechanical index may be a little bit too high where the bubbles are getting destroyed, so it's not completely filling the LV cavity. You can also see that, as I showed you in an earlier case of LV dysfunction due to poor contractile LV due to stasis. So some of these cases you may need to, if your mechanical index is already set right and your LV dysfunction is already present, you may need to give a little bit more contrast and allow the left ventricle to fill. These are practical points. If you have a rib shadow right in the center of your contrast imaging, you may need to move to a different intercostal space and imaging. And for papillary muscle shadows, which can sometimes confuse you when you draw your volumes, you would need to angulate your probe to avoid that pap muscle coming in view. So let's now that we've completed our contrast strip, let's now revisit our question 1. So one of the key characteristics enabling current use of microbubbles in clinical contrast echo is the non-linear oscillation property. We talked about the fact that as the acoustic wave of the ultrasound beam hits these bubbles undergo non-linear oscillation and changes in size and shape. B is wrong because you want the bubbles to be smaller in diameter. You do not want the bubbles to be easily diffusible. You want to have a stable gas. And having nitrogen and oxygen as content of your gas causes easy diffusion. So that's not the optimal gas. And that's why, as I showed you, what gas you have, like perfluorine, and what shell you have makes an important difference as for a superior quality contrast echo. What is the most likely reason for incomplete opacification noted in the image shown here? So here you can see that the right ventricle is fairly well opacified, but the left ventricle is struggling for opacification. And you can see that the mechanical index here is 1.3. So this is not an optimal mechanical index for this patient. So this needs to be actually turned down. So there is nothing wrong with your, in this the bubble destruction is not related directly to filter setting. And there is not too little contrast because you've already opacified your right ventricle pretty well. And we know there's no IV infiltration because things are working pretty well on your right side. And just as a reminder for you, the mechanical index is directly proportional to the ultrasound beam's peak negative pressure. And these can be potentially questions for you, that the MI is inversely proportional to the frequency of the beam. And typically the MI is, you can actually look at your MI on your screen, and there is a button which actually gives you the capability of adjusting your mechanical index. What about the majority of intramyocardial blood volume? So we've talked about this, that the microcirculation, which is where 90% of your myocardial blood volume resides in your capillaries. So what you're imaging by myocardial perfusion, I'm not talking about endocardial opacification, I'm talking about myocardial perfusion, you are actually imaging capillary integrity. Even in nuclear, for that matter, when you see a perfusion scan, the perfusion cannot distinguish between epicardial, but the actual isotope sits in your microcirculation because that's where most of your blood volume is based out of. And then the depicted cine clip shows which of the following. So here you can see something very interesting. This is your low mechanical index imaging interrupt. See, so I just want you to focus right here. So your MI is set at 0.18, but then you interrupt it with a high flash MI of 1.2. So here is the normal myocardium filling normally. And then the moment you do the flash, you can see that the myocardium gets dark and then fills normally. However, you have a significant wall motion abnormality in the periapical region of the ventricle. You start off with lack of microbubbles in that area. And even with flash imaging, you can see that there is absolutely no replenishment of microbubbles. So this basically indicates that this patient has an infarct with microvascular no reflow. And why do I like this? I think this has got great promise, because when we do actually when we actually do PCI or give thrombolytics for infarctions, we look at, is there greater than 70% ST segment resolution on your EKG as a clue for microvascular integrity. There is direct relationship between lack of ST segment resolution and lack of microbubble perfusion, because microbubbles can get into the myocardium with blood flow as low as 0.3 ml per minute per gram. So if you don't have even 0.3 ml per minute per gram flowing into your microvasculature, that is not a viable territory. So the correct answer here is infarct with microvascular no reflow. And then finally, for those who, I don't know if anybody put anything on the chat button here with regards to what this case would be. So this is a complex congenital heart patient who underwent palliative surgery, as we showed. And there is a contrast saline study done here. And this is not, I know we don't use the Mayo view, so this is our traditional view. And you can right away see the first thing to note, obviously, when we deal with congenital heart disease is that what is where, because things can be all over the place in congenital disease. First is to define what is there atrium ventricular concordance. So in an adult patient, at least I would start with that way. So you can see that here you have the atria opening via a valve into another chamber. And then on the right side, you see the atria opening with the valve into the chamber. You can see that this valve is more apically placed than this valve. So we know that this is the tricuspid valve, which means automatically this has to become your right ventricle. So which means this is your left atrium opening via mitral valve to the left ventricle. So there is atrioventricular concordance on both sides. So yet this patient now has what looks like pulmonary vein blood draining into the right atrium. So this patient most likely, and again, I would agree that you would need additional images, but this patient most likely had detransposition of the great vessels with a baffle procedure, so that your systemic, I misspoke. So this is systemic venous baffle coming into the right atrium, or the pulmonary venous baffle coming into the right atrium, I think I'm right. And so what we're looking for here is that your pulmonary veins have to come into your right atrium, drain into your right ventricle, which then opens into your aorta. And then your systemic veins are baffled into your left atrium, coming into the left ventricle. So when you do your bubble study, the left ventricle fills. And what we're trying to assess here is actually the baffle leak. So that's what we're trying to do here, suggesting that this baffle is relatively intact. And so this is a baffle leak test done in a patient with postoperative detransposition with a mustard baffle. So I think I have about 5 minutes left, I'm happy to answer questions, or I'm happy to show you some additional cases. I leave it up to Jay and the group to decide what you guys want to do.
Dr. Anant, we can finish your cases, and then there are only 2 questions. I think we have time for the 2 questions later.
Perfect. Okay, so let me show you some cases just so to illustrate the value of contrast. So you have a 51-year-old man with new onset acute systolic heart failure. So all of us would agree that this patient has significant left ventricular dysfunction with wall motion abnormalities. And this is an example of, I wanted to show you this both from the left ventricular dysfunction standpoint, because you may get this as a scenario for indicating swirling. So you can see swirling of contrast in this particular case. And this can be due to various reasons. System settings, we talked about high mechanical index here. The mechanical index is really not, you can definitely lower it, but it's pretty decent. Or the dosing is low, we talked about it, but it looks like the dosing is fairly accurate because you can see that the right ventricle is opacifying very well. Or your administration was low, but this is actually a bolus, it was not an infusion. And finally, poor LV function, which is most likely the reason why there is a struggle to actually fully opacify the left ventricle. Here is a 55-year-old healthy male with palpitations suspected to have an apical aneurysm in an outside hospital. So he was brought for evaluation, and again, a very challenging echocardiogram. You can see the right ventricles okay, but the LV apex is not well seen. However, when you give contrast, you actually see a focal outpouching of the left ventricle. And so this was mistaken as a left ventricular aneurysm, but it is actually an LV apical diverticulum. Sometimes the apical cap of the left ventricle can get extremely prominent and, and become what we call an apical diverticulum. And typically, these are, if you do MR imaging, you would not see any delayed enhancement or anything like that. And most of these can be also diagnosed by some degree of contractility, although those can be fairly challenging. And so here is a case of a 45-year-old male with VFib cardiac arrest, CAT showing non-obstructive CAD. And so if you look at this particular case, there is significant hypertrophy in the mid portion of the ventricle with apical akinesis. And clearly, if you look at this one, there appears to be what looks like a thrombus, and it was actually interpreted initially as a thrombus. Pre-contrast. And so the interpretation was correct in the sense that this was interpreted as a mid-ventricular apical, mid-ventricular HOCM with apical aneurysm, and a suspicion for thrombus was definitely raised, which I think is very reasonable. But when you do the contrast echocardiogram, very interestingly, something was seen, and this was confirmed. We did do an MRI for other reasons to confirm, and you can see clearly here that there is significant apical stasis. But what this is actually an apically displaced papillary muscle attached to the apex of the ventricle, traversing the middle portion of the ventricle. So this turned out not to be a thrombus with just poor flow and stasis on MRI, which confirmed that this was an apically displaced pap muscle, which, as all of you know, can be seen in patients with HOCM. Here's a 25-year-old woman presenting with subarachnoid hemorrhage, status post-clipping, mildly elevated troponins. And again, very challenging non-contrast images, not able to see the ventricle well at all at this particular point. So this was deemed not interpretable properly for wall motion. And so when we brought it back for contrast imaging, you can see right here that the left ventricular apex segments contract very well, but the basal and mid segments are significantly hypokinetic. So this case was deemed to be a case of inverted or Takotsubo, which can be seen obviously in patients with acute cerebrovascular or other acute insults. So we could not have figured it out without contrast imaging, obviously. And then just to show you the value of contrast, obviously, liver transplant is a scenario where we look for pulmonary artery pressures. So this is a patient with poor TR signal pre-contrast, and you can see that contrast salvaged the TR signal very nicely to be able to give a fairly good diagnostic PA pressure for this particular patient and avoiding right heart cardiac catheterization. And so I think I've reviewed this case already. And then I just wanted to finish up with this particular case, which is a patient with diabetes, hypertension, and CKD with progressive shortness of breath for 1 week. EKG showed non-specific ST segment changes and troponin leak. And you can see, for starters, the left ventricle appears to be working okay, but the RV is not very well seen. And in some of these views, with a little bit of a tilt, you wonder whether the right ventricular free wall is definitely hypokinetic. So here again, with contrast, you can now see that the right ventricle free wall is definitely abnormal, and angulation, particularly now looking at the parasternal long axis views, you can actually see that that area is actually bulging outward rather than actually contracting. And the VQ scan ultimately was high probability. So hopefully these cases kind of give you a flavor for the value of contrast imaging, which is still widely underutilized in the United States. And I'm hoping that this would serve as a good review for you to be able to read further. And I wish you all the best for your board exams. Thank you.
Thank you very much, Anand, for a phenomenal talk. We have 2 questions in the chat box. The first one is, can you comment on contrast use in pregnancy? Yeah,
so I think that's a good question. And the answer is, at this time, there is really no data for the safety of contrast in pregnancy. So in general, it is recommended not to use it at this particular point.
And the second question is, given that complications from contrast use are negligible, why don't we use contrast in every echo study, regardless of endocardial border visualization? For example, the example that you showed of apical HOCM, the diagnosis in many patients can be missed.
Um, well, in the ideal world, yes, but I remember that with every dose of contrast comes cost. So typically that varies anywhere between $95 to $120 per vial. So obviously that would be a huge additional burden. We do, for example, I'm sure you all do thousands of echoes. We do about 20 to 21,000 echoes per year. So that would be a substantial financial burden. Having said that, I would say that the one area, and even the American Society of Echo recommendations say this, is cardio-oncology. And I think this is very crucial, is regardless of left ventricular image quality. I think cardio-oncology is an area where I think contrast imaging should definitely be considered at very low threshold to be used or used routinely. So because the normal variation of echocardiographic EFs is between 9 to 12 EF points, even in expert labs. In our lab with contrast, it's about 7 to 8 points. What do I mean by that? So if I did an echo and I actually asked somebody else, or did the EF and I asked somebody else to do the EF again, we may have about a 9 to 12 EF point variation. And even within the same observer, you would have some variation. That's not acceptable for cardio-oncology because we are looking at 5-point EF changes and other things. And that's why MUGA has always been at the top. But with the advent of contrast echo, strain imaging, I think the attention to echocardiography has shifted back. But with that comes responsibility, which means that in the labs, when we use contrast, we have to do internal quality control to ensure that our lab inter-observer and intra-observer variability is within acceptable range. Because if we say the ejection fraction is one time 55% and the next time 63%, what do they do with chemotherapy at that time? So I think I think the cost implications and unnecessary exposure of patient implications is definitely against routine use of contrast. But cardio-oncology, the implications for patient treatment is high enough that that's what we do. We try to pretty much do contrast in literally all patients unless there's exquisite imaging, in which case we routinely do 3-dimensional ejection fraction.
Thank you very much, Dr. Anand. I'll have Dr. Ashwa take over. I'm not sure if Dr. Ashwath is still on. I've texted her, but thank you very much once, Dr. Anand.
Okay. All right. Thank you all and wish you all the best. And hopefully this was helpful for you. Thank you.
Thank you very much, Karthik. That was an excellent review. Really appreciate your contribution to the lecture series. Thank you again for your time and your
Thank you. Oh, thanks for the opportunity. Thank you.
I'd like to thank
Bye.
you all for joining us on this weekend, this Sunday, and we will see you all again on next Saturday at 9 a.m. Central Time. There's the list of the topics that you will be seeing. We'll be talking about cardio-oncology, cardiac masses, infective endocarditis, and interventional echo. Have a wonderful rest of the weekend, and we'll see you all next weekend.